conseguimos, durante esta segunda manhã e este segundo dia da conferência, unir num mesmo espaço, físico e virtual, alguns dos melhores especialistas na matéria e tratar temas especialmente contundentes no presente e no futuro.
Quanto dá para conquistar em 57 anos? Quantas pessoas novas dá para conhecer? Quanto é possível plantar e colher? Quantas vezes dá para se emocionar? Quantos novos sotaques dá para falar? Banco BRB. Há 57 anos, melhor, mais completo e ao seu lado a cada conquista.
Dear participants, good morning. Please take your seats as we are about to begin the first session of the day. Welcome to the 16th World Conference on Bioethics, Medical Ethics, and Health Law. This conference is an organization of the International Chair in Bioethics and of the Federal Council of Medicine of Brazil under the auspices of the World Medical Association. The first session of the day is titled Education of Healthcare Professionals. We now invite Dr. Ruschel Franco de Souza to the stage, who will be chairing this session. We have 6 esteemed speakers we call to stage. Dr. Christoph Ostgate, who will present on the new age of palliative care. Dr. Ostgate is joining us remotely via Zoom. Professor Thalia Arawi, who will discuss challenges for medical education in the 21st century. Dr. Arawi is joining us remotely via Zoom. Dr. Daniela Kader, who will talk about principles and practices of bioethics education. Dr. Kader is joining us remotely via Zoom. Dr. Mary Matthew, who will discuss bioethics education in India. Dr. Matthew is joining us remotely via Zoom. Dr. Paula Castello, who will present on ethics, commits, and education for bioethics. And Dr. Jasna Karatiti Zanetti, who will discuss education for bioethics as a global endeavor.
Right.
We now hand over to Dr. Ruschel Franco de Souza to coordinate the session.
A very good morning to all our participants. Today, the third day of this outstanding 16th World Bioethics Conference being organized in this beautiful city, Brasilia. So welcome. Today I am Professor Russell D'Souza from Melbourne, Australia. I am the head of the Department of Education, but also the co-chair of the Global Network for Medical Health Professions and Bioethics Education, part of the World Federation of Medical Education, and of course based in Australia. So today we have an outstanding session focusing on education of healthcare professionals, one of the important arms of this International Chair of Bioethics. And to bring this together, we have an outstanding number of presenters from around the world. So we have face-to-face, as well as from Germany, India, and Israel joining us, and probably from Lebanon, hopefully, that will also happen. So we have this session that's going to take us through a number of areas that will find interest in all of you. Each of us will have definitely something to learn from this, something to understand, in particular, what's happening around the world in the area of education of healthcare professionals. So with that, we're going to take on this wonderful session. We're going to start with, I think it's the Zoom. Is that right? Our first session is going to be a Zoom session, and it's going to be Dr. Christoph Oscat. I hope I'm pronouncing it correctly, but he's from the University Hospital in Erlangen in Germany. Of course, the topic is going to be of great interest. It's the new age of palliative care. So I'm going to welcome Dr. Christoph to join us from Germany and take us through this presentation. Over to you, Dr. Christoph.
Thank you very much. I hope you can hear me.
Yes, we can.
Okay, thanks to all this technology, I can be part of your conference all the way from Germany over to Brazil. So hello from my side. I am probably a bit of a colibri within this session because as I learned, it's on education. Palliative care has a lot to do with educating the public, with educating healthcare professionals. But my focus will be a little bit different, but I hope you will apologize and still follow me. I'm trying to have a look on the question whether we have entered a new era in palliative care within the last decades. Just to remind you what palliative care is all about, we are taking care of patients at their last year of life or at their end of life. And the main focus is on quality of life, really integrating patient-centeredness, coordination of care, communication and decision-making. And we are not, doctors do that sometimes, look only on the physical side of suffering. We always look on a multidimensional perspective, integrating psychological, social, and spiritual aspects equally in our care for the patients. We work on a multi-professional level, so we work with nurses, psychologists, spiritual carers, physiotherapists, music therapists, you name it, and we work strongly on an interdisciplinary focus. So on the wards, we always have people which are specialized in palliative care, but also in other disciplines, for example, internal medicine, or anesthesiology, or oncology. And our aim is to accompany the patient in his final phase of life, but also in the dying process, and give him the best medical and humane care as possible. And one of the main focuses is a good symptom assessment and alleviation. If I'm talking about palliative care and did we enter a new era, I could also talk, as you may have read in the abstract, about the interplay and the development of palliative care and medical assistance in dying, really changing the scene of palliative care. Or I could talk about the global role of palliative care, or the changed role of palliative care during and after the corona pandemic. But I want to concentrate on a very innovative issue and question one of the major and oldest paradigms in palliative care. Let me, before I reflect on that, have a little look on the forefathers and mothers of palliative care. Cicely Saunders, which has been one of the founders of modern palliative care, Elisabeth Kübler-Ross, who became very famous for her interviews with the dying, or the surgeon Balfour Mount, who was the first one to integrate the term palliative care into the field when he wanted to open a so-called hospice ward in Montreal, Canada. And when I was talking about one of the oldest paradigms of palliative care, it was the change of sight on medicine back then in the 1960s. And Cicely Saunders tried to focus care more on or less on technology. Intensive care had grown quite a bit in that time, and treatments were possible that we couldn't have imagined in the time before. But the person behind it, the person behind the patient kind of got lost over time. And she wanted to bring this back into medicine, and palliative care should depend less on the technology impedimenta of intensive care than on personal skilled care. And she subsumed this paradigm under the name high person care and low technology approach, which is in fact one of those major paradigms of palliative care. But I want to see whether this is within the context of a increasingly digitized and with developments in technology, whether this in this world whether this paradigm is still right. From a clinical perspective, we have a few big challenges that has not been solved so far. And to illustrate this a little bit, I want to take you along with two people. Joe and Jan, they got to know each other when they were in their young age, and they fell in love, and they decided that they want to spend the rest of their lives together, and they got married, and Jane got pregnant, so they started to build up a family. Their lives made curves like all our lives did that, do that. They have had 2 children, and over the time they got older, as we all will get older, hopefully. And there was a time when Joe gets really majorly ill. And Jane was taking care of Joe in that time. The problem was that he was also, with his major disease, cognitively impaired. And the problem you see here is that there is a patient where we try to take care of his symptoms, but we don't know whether the drugs really have an effect, or maybe even have a side effect. And we can't say anything as long as the patient is not able to give us insight how he feels, whether he is really suffering. And Jane, as they had spent a long lifetime together, said, if we have the impression that Joe may be in his dying phase, that we would call her to come to the ward. So, as it happens once in a while in a clinical context, we couldn't really recognize whether the patient was dying in a certain time frame, and we missed to inform his wife Jane at the right time. So what she had promised him to be with him in this moment, we were not able to achieve. And this is just a short insight, and maybe you can understand that we are looking at some clinical challenges in palliative and end-of-life care, in particular in patients that are not able to give us more information about how they feel, how their symptoms are, whether they're in pain, whether they're have feelings of anxiety, whether they're in dyspnea, whether they're nauseated, and a second clinical challenge is that it is really hard to define and prognosticate when a patient is dying. And the question here is whether technology and new technologies, sensoric technologies, or even large language, artificial intelligence or machine learning approaches may help us. And we at our unit started to cooperation with the technology department here, and they developed a bioradar. To give you an insight a little bit how that works, this bioradar sends out a electromagnetic wave, and the radar is able to detect minor movements on the body surface. And when you touch your heart, you feel that there are minor movements on the body surface. So this radar could be able to detect heart rate by calculating the difference between the wave that was sent out and the wave that is reflected. And you see here the raw data from the body surface, and if you apply an algorithm, we are able to detect and to determine, without touching the patient, his heart rate. And this is not done to save the patient, so it's not for intensive care, but to get an insight in how the patient may be, how his status of health is, and it may even have information about his suffering and his symptoms. So the practical advantages of this new bioradar is that it is no burden at all to the patient. So you probably have, when you think about monitoring, the metaphors or pictures of an intensive care unit with all those cables going to the patient. No, this bioradar is able to detect heart rate on distance, and even it could penetrate, so it goes through clothing, mattress, and bed covers, and it does not have any health risks. So the transmission power is up to 99% lower than a standard cell phone that we have always close to ourselves. So when we started this project, we had to find out whether it really does what we assume it does. So we had to validate it against gold standard measurement tools, and that we did in our laboratory. You see here a scene with a healthy test subject, and you can see here it's the bioradar, and here it's so-called a task force monitor, and where we can depict ECG, beat-to-beat blood pressure, and many more aspects, just to compare what is measured here touchless to the regular cable-bound monitoring. And as our hypothesis was, this new bioradar is very precise. You see here the calculated radar signs, and you see here the ECG, and we were even able to depict the heart sound. Here's the first, and there's the second heart sound, and this correlates also with a phonocardiogram. And in the validation, we could show that there is a very, very tight correlation between the radar and the ECG. Why may that be important for us? What does that give us information? We can get an insight how the patient, how his health status is, as you may imagine, also from an ECG. But if we could touchless monitor the patient, we could also get an insight into the patient's stress level. The more precise you detect heart rate, the better you can determine what we call heart rate variability. And heart rate variability is a surrogate parameter for the balance of the sympathetic and parasympathetic nervous system. So in a patient that is stressed, the sympathetic nervous system is active. In a patient that is relaxed, the parasympathetic system is active. And if we have a wide range in the heart rate variability, we can expect that the patient is fine. And if we have a very strict, not very variable heart rate, then we can expect that the patient is stressed. And we could also use this to determine drug effects. So if we think or we expect a patient that is not able to talk to us, that he is in pain, and we give him a drug, the heart rate variability should become better. The heart rate should go down, and this might help us also to be closer to whether the patient is suffering or not. And this is what you see is the data we drew from healthy test subjects to validate whether the technology is working. But the interesting issue is then whether this is also true for the patient. So we integrated this radar system. You can see here 4 radars put under the bed of all beds in the palliative care unit, and in case the patient or his legal representative was willing to participate, we measured the patient's heart rate during his stay at the palliative care unit. And what is true for the healthy test subject is also true for the palliative care patients. And this is very fresh from our research department. Also for the patients, where we did a gold standard validation with an ECG, we could see that there is a high and close correlation between radar on the one hand side and ECG on the other hand side. And we started first tests whether we can get an insight into the well-being of the patient. For example, this patient here, you see here's on the x-axis is the time, on the y-axis is the heart rate. We could see that this patient was suffering from pain and nausea. Here is when the patient received his medication, and that was hydromorphone, an opioid, and something against his feeling of being nauseated. And you can easily see that the heart rate is going down, and we may have the impression that the symptoms that the patient was suffering from are getting better. This is one side of the medal. The other side was the question whether this helped us in better diagnosing dying. I said that it's a clinical problem, that the family cannot be with the patient on the palliative care unit the whole time. Jane was too frail, too old, but she asked us to inform her right in time. But clinical signs are very weak, and sometimes the nurse goes into the room and has the impression that the patient is fine. And the next time she enters the room, the patient has died, and we might have missed to inform the family right in time. And this is one of our measurements. We also had patients under review that died in the time we had the bioradar active. You can see this is raw data here. You can see that here the patient is still alive, then the patient died. There's no signal anymore. And then you see here, 45 minutes later, again, that the bioradar is active, but that is not the patient. That is the time when the nurse entered the room and found the patient dead. So there was a time of 45 minutes where we didn't know that the patient had died. And we are not clear whether in this data here may even be some information to better prognosticate, at least for a patient who's dying naturally, whether there is some data in there and some information giving us a hint that the dying phase may have begun. Here you see the last 24 hours of a patient. You can see that 24 hours before the patient died, the heart sounds very well segmented, but the further 12 hours or even 1 hour before death, that the heart sounds deteriorate, and the same is true for pulse wave and the change in breathing rate. And maybe with some machine learning algorithms, we may in future, at least for the natural dying process as it is mainly on the palliative care unit, to get a better insight into prognostication of dying, and that may help us clinically as we are better than in informing the next of kin. Just to give you one more example, what the new technology and the machine learning approaches may help. We have there's a growing body of evidence that even in the use of routine documentation data from the electronic medical records, we are able to prognosticate patients, for example, to prognosticate what symptoms may arise in a certain patient. And for example, if we integrate this into our digital records, we could be shown, for example, a red flag that raise awareness for healthcare professionals to look at a particular symptom. For example, here we were able to prognosticate or to define the probability for the symptom anxiety in patients. So what I would say, we have to leave this old paradigm, low tech, high touch. I think it was a very important paradigm to evolve palliative care in a context of a very and increasingly technical medicine, but where technology put the patient under high burden. We probably have to, we want to stick with high touch, high personnel, keep the person in the center, but then we should be open to have the clinical teams be supported by technical and digital innovations. And all this can only be done if we at the same time analyze what are the ethical, legal, and social implications of this new technology, of this innovative technology from the start, from the development until the time of the use. And our team has developed, and we're almost so far to publish, is a framework to conceptualize social implications of health technologies in palliative care. And we have published together with our regional local ethicists how smart technologies impact the total care principles of palliative care. So at the end, I started with a question mark, and now I would end with an exclamation mark. I think we are entering a new area in palliative care. I've just shown this bubble of new technologies. As I said in the beginning, I could have spoken about many other issues, but due to the restriction in time, I concentrated on that focus. And I just want to thank you for listening, and I want to thank also my team that support us in this research. Thank you very much.
Thank you, Christoph, for that interesting information. Certainly, the challenge, one of the challenges is diagnosing dying, something that all palliative care have difficulties, and of course that leads to your story of Jane losing the ability to be with her husband or partner. Certainly this bioradar brings the, as you rightly put, new age palliative care, where we are bringing technology to assist with that very important aspect of diagnosing dying in the palliative care, one of the areas that can make a big difference. So it was very interesting. Thank you very much for that. And as our organizers want, we're going to be having questions at the end. Is that right? Yeah, so we're going to take the questions.
Sorry, may I interrupt you? Because
yes.
I have a problem with time. I'm not able to stay for the whole session. I got a little bit messed up between the European and the Brazilian time. So I have another appointment afterwards. So if there are any questions, and as I'm not typically in this educational issue with my talk, maybe we could have the questions now, and you would give me the chance to partake at my other obligations afterwards.
Yeah. All right. Let's give you one question that we could. Any of you would like to ask one question to Christoph from Germany? I'm delighted you have two teams. Is it one at Elgin and one at Hamburg? Is that right? Are you collaborating?
Yeah, but it's not. These are my collaborators, and these are the technical partners in Hamburg. Because without them, we would not be able to do that.
Right.
Because we're doctors, we are not engineers,
yes.
And they're really big brains. Those engineers.
Very good. That's great to see the two combining. Question? Anyone for a question to Christoph? Yes, sir. Please announce your affiliation and ask your question. We could have just a minute. We'll give you the mic.
Jorge Santos, Faculty of Medicine of Porto, Portugal. Thank you, Christoph, for your interesting communications. Can you speak about the pitfalls of new technology, please?
I think you put the finger in a very important point. There are different pitfalls that are possible. We're interviewing patients, and many of them are very supportive of being part of the research, and they would really be happy if we integrate this into our clinical work. But we also have negative feedback. For example, people saying that the dying phase is something holy. Should we really have technology in that time? But for me, from that perspective, it's always to be used only if the patient consents. There's a second, and this is rather a legal problem, because the bioradar doesn't differentiate between the patient and the relative sitting beside the bed. He is also able to depict the heart rate of the informal caregiver or even the nurse. And what do we do with information that derives from the analysis of that? What happens if we depict, for example, cardiac disease in a relative? Are we obliged to tell him? Or is there also the right not to know? So there are so many. And what does it change? And so I have the ethical issue, the legal issue, and the social. Does it change something in the relationship between the patient and his informal caregiver, or between the patient and his healthcare professional, his nurse? So there are some pitfalls, and we are looking at that. There's no development of this technology without looking at the ethical, legal, and social implications. And there's probably still a lot to come. But from my perspective, the benefits outweigh the possible pitfalls.
Right. I think that's the principle that we follow in terms of benefits versus the other areas. But certainly, any new technology, as we have had 2 wonderful sessions, brings in the issue of ethics, ethical issues and legal issues. And you rightly have put that, and we'll probably work through it. You'll work through it over the next few years or months or whatever. Anyhow, thank you very much for that, Dr. Christopher, and we enjoyed your presentation. Thank you very much. All right, I understand that the next presenter has not joined. Am I right? From the American University at Beirut. So we're going to move on to the next presenter, and this, of course, is Professor Daniela Keda, one of my good friends, colleagues. She is the head of the behavioral sciences in ICB, but more importantly, she's the co-chair of the Department of Education and a very important faculty member. Dr. Daniela Keda does her work internationally on her behavioral teaching of emotional intelligence and so forth, well known for that. And we're going to have welcome Dr. Daniela Keda from Israel, and she's going to be talking about the principles and practices of bioethics education. Thank you very much, Daniela, and welcome, and over to you.
Great. Can you hear me? Good evening, good day, good morning. Can you hear me?
Yes,
Hi,
we can.
how are you? Yes. Okay. I'm very happy to be here. It's an honor. And when I prepare those few minutes that I have, I think 20 minutes, I ask myself, this is a so huge issue that I have to deal with, what I want you to remember and what I want you to go with back home. So when I speak about the principles and the practice of the bioethics education, I thought the 3 words will be appropriate to show you or to present what I mean. First of all, the 3 words will be to prevent, to promote, and to present. And to prevent, to prevent, to protect, and to promote. This is the main issue in teaching bioethics and be a doctor. And first of all, I ask myself, what is the target by teaching bioethics? What we want to achieve? What are the difficulties? How we really develop motivation in the students to use bioethics, not just as an issue or just as something that I think about it and something that I write about it and something which is just a word, but using bioethics as a language, as an immanent language that I really touch it, not just by my cognitive part, but I touch it with my emotions and actions, because any issue, any subject, bioethics is a subject, it's a very huge subject, but any subject that I teach, I don't just touch it with the informative data. Bioethics is one of the subjects that I have really to teach it with all my heart, with our feelings. And those feelings are really lying in the emotional intelligence that is the toolbox how to teach bioethics. Because emotional intelligence is a three-angle way of teaching bioethics. It's the cognitive part, yes, thinking about it, is the emotional part, feeling something when I use bioethics, and is how I behave, how I choose to behave when I combine between the thinking and the feeling. Because medicine is not just science. Medicine is art, is something that I can really not just think about it, but I can feel it. So how I'm doing it, how I have to do it as a teacher, as a lecturer, as a trainer of bioethics. And then I thought about the Hippocratean thought, the modern version of Hippocrates, and I have three main points which are so important. The first one in the Hippocrates Oath is I will remember that there is art to medicine as well as science. When we think about art, we think about flexibility, we think about being creative, we think about touching people, we think about touching the, no, just a minute, touching the person, not just looking at the ill people, like the illness, but first of all, we don't touch the illness, we touch a human being which is ill and need our help. We touch somebody who needs to be honored. We touch somebody who needs the autonomy. We touch somebody which is a partner of us. This is a principle of mutual communication between the doctor and the patient, between the caregiving and the take-giving. This is a mutual dialogue. It is not being above somebody, it is being with somebody. Empathy is sympathy, is we combine between empathy and sympathy and listening as a part of being a doctor. Secondly, in the oath, in the Hippocratic Oath, is I will remember that I do not treat fever, I do not treat cancerous, I do not treat just the body, I treat sick human being whose illness may affect the person's family and economic stability. This is not just the ill person. This is something which is so holistic in really showing that you are not just treating one person, you are treating some people which are connected to the ill person. This is one, the family, the friend, and something which is so much wider. So bioethics is a wide issue that I have to think about, to feel about, and to use. The third thing is I will remember that I remain a member of a society with special obligations to all my fellow human beings, those sound of mind and body as well as the infirm. So I will connect between mind and body, which is so huge, much more than just doing right or doing wrong. It's about benefit and harm. What is beneficial? What is harm? Beneficial is not just treating the person. Beneficial is to really see the human being as a whole, to see human being as somebody, as you, okay? With your feeling, with your mind, with your body, with your emotion, with your hope, with your despair. Those are the whole feelings. And when I speak about to prevent and to protect and to promote the 3 Ps, I speak about to prevent a dialogue which is just really treating the disease. To protect is to protect the ill person, the person that I really treat, from being really just a number, but really to protect the human being as a whole, as I spoke about it before. And to prevent is to prevent the way of not understanding what does it mean being human and being human. To really be in a very careful, touching way to treat the ill person. And how I teach bioethics, this is the main point. If I speak about the principles I already have mentioned, so bioethic teaching is not so easy because it's such a very sensitive issue and subject, because we deal with human beings. So I teach and I train the way of teaching bioethics when the emotional intelligence is a toolbox. For example, how we teach so that the student who really listen can really be involved with his or her emotion in the teaching. How I open a lesson, how I really use didactic tools, not just speaking, but using didactic tools to show, to touch the student, ask questions, dilemmas in bioethics, osmosis learning that Russell, yes, and we speak so much, because the art of unconscious learning, it is where they stop studying materials and start absorbing the materials, not just teaching the material, but really digesting the whole materials of bioethics. I want to go home when I'm a student in bioethics and go home and say, oh, I really have to think about it. I really have to think about it, how I feel when I really hear a problem in bioethics. And I want to give some example when I teach bioethics in the age of the COVID-19. We see something which is so important, the dynamic, the changing, sometimes unclear, puzzling, uncertainty, ambiguous, the concept of bioethics. The way I treat, for example, when I treat, the elder people in the COVID-19, we try to really treat them by using isolation. And we thought, I think all over the world, but in Israel, we isolated those elder people. So the doctor thought it will be the best way to keep them okay and to keep them healthy. But if I speak about about benefit and harm, we saw that the harm of isolating an old people from the family for a long time damaged them so much that they really suffered so much. And when I really spoke about it, and I saw some films to my students, and I asked them, just try, students who are 25, 30 years old, try to think about you as a 70, 80, 85 years old, who is isolated from the society, who is isolated from, from the grandchildren, from the family. Try to imagine how you feel, what is benefit and what is harm. And this student told me, he was 35 years old, he told me, really, Daniela, I don't know. Now, when you ask me to feel it, to close my eyes and try to feel and try to really do something which I never did it. I never think about it as something that I can feel and be, instead of these elder people. So, Paul Gauguin, he said something which is so important. He said, I close my eyes just to see. And this is the main thing that I tell you. Close your eyes before really thinking about how you teach bioethics, and ask yourself, what is the main thing or some things that you really want to give to your students? Not just the informative data, not just the academic things of giving and teaching and training, because this I can really just press the button and see the information that I need and that I use. But as a trainer, as a teacher, as a bioethics person, you have to be something more, something added, more added value for your student, something that your student cannot really gain or reach but by using the button. Something when you stand as a lecturer, when you stand as a trainer of bioethics, is not just showing the knowledge. It is much more than knowledge. It is something that is beyond the principles of bioethics, beyond the 15 principles of bioethics. And we in Israel know now, and not just in Israel, in the world, that we need so much our feelings as human beings. And I think that when we will teach in such a way and we will use it, it will be much more, we will live in a better world of communication between people. Because first of all, bioethics, doctor and patient, is the connection between two human beings who need really a hug, honor, understanding, listening, and a language which is much more beyond informative data. Thank you very much.
Thank you, Daniela. Thank you for that your presentation. As we've heard, there's much to Daniela's topic of teaching bioethics, but the use of emotional intelligence. As Daniela, we're going to have questions at the end, so kindly stay on so that we will open your to the audience here for questions. Okay, thank you very much for that. And
Thank
of course,
you very much for listening.
Yes.
It's a pleasure. Thank you, Marcel.
Thank you. And of course, we are now going to have Professor Mary Matthew, who should be here, but for reasons beyond her control is not here. She is the head of the Department of Bioethics and Art, but very importantly, she is the deputy head of the International Department of Education. She's a pathologist, head of pathology, and an ardent medical teacher. She currently is the Secretary General of the Association of Medical Educators of India, which harbors the world's largest medical education or educators, I think 114,000 from 715 colleges. So she's going to speak, and she also heads the program of our chair, the international chair in bioethics, or the erstwhile UNESCO chair in bioethics out from Haifa. And I think Professor Mary Matthew is going to be taking us through the bioethics education in India. Incidentally, one of the large programs of this chair in India. So, Dr. Mary, Professor Mary Matthew, welcome, and I hand this over to you.
Thank you very much. Can you hear me?
Yes, we can, Mary.
Thank you. Thank you very much, Dr. Russell, and good morning to all in Brazil. And at the outset, I'd like to thank the organizers of the 16th World Conference in Bioethics, Medical Ethics, and Health Law for inviting me to talk about a topic which has been my focus for the past 13, 14 years, has been a passion for me, that is bioethics education in India. Now, as you know, bioethics is not new in India in terms of having it in medicine. If you look at the pre-Vedic period, that is, it's divided, it's a different period compared to BC. It amounts to 1000 BC to 1 to 2 BC. There was what is called as a Siddha text, or Siddha is a branch of medicine which has been practiced, or it came from the southern state of Tamil Nadu in India. And during this time, the Siddha form of medicine also talked about what a physician should do and what are the ethical duties and that he or she, rather it was always he, should follow in medical practice. But many of you know, when you talk about India, you have heard of Ayurvedic medicine. And that is what is now well known in India. The system of medicine, the ancient system of medicine in India is Ayurveda. And it was this physician called Charaka who wrote about the texts or the ways that a physician should behave when it comes to practicing medicine. And so these are some of the values that a physician should have when he practices medicine. And it goes like this, that a physician should pledge himself to the relief of his patient, never abandon his patient, never take sexual advantage of his patient, never treat a woman without her husband or guardian. So these were some of the principles that were to be taught when practicing Ayurveda. And the essence of this medicine was, he who practices medicine out of compassion for all creatures rather than for gain or for gratification of the senses surpasses all. So that was the main theme behind the Indian system of medicine. But as time went on, India adopted the Western medicine system of medicine, and now the oath that is taken by the students is a modified version of the Hippocratic Oath. But there is a move now in India to move back to the old oath that was given in the Charaka Samhita, and there are many followers of who are advocating to take up the Indian system of medicine oath rather than the Western philosophy. When we talk about ethics in India, or it was hardly known maybe 10, 15 years ago. Much of ethics that was understood under the umbrella of ethics was research ethics. And the Indian Council of Medical Research was responsible for formulating these guidelines. And this council is the one that makes the regulations for all research in India, and it conducts training in bioethics and through its bioethics cell and in research ethics. So this guidelines was formulated in 2012. But when it came to medical institutions, was bioethics or medical ethics being taught in the curriculum? Now, there was, in the past 10 years, a decade ago, there has been a move, there has been a lot of violence against doctors, a lot of litigation against doctors. And this has brought ethics into the forefront. But if you look at the history of ethics being taught in the medical curriculum, there were only two medical schools in India. One was the St. John's National Academy of Health Science in Bangalore in India that introduced ethics into the undergraduate curriculum. And they had three phases. That's the first phase, they focused on values. The second phase, the principles of bioethics, and the final phase was on clinical ethics. And the interns had a forum for ethical case reviews. The second medical institution that that was teaching medical ethics was the Christian Medical College in Vellore in India, and they had a similar model, a semi-structured module in medical ethics, and this was all what was there maybe 10 years ago in the Indian medical education system regarding ethics. Now, in June 2011, the Indian Council of Medical Research launched a postgraduate diploma in bioethics under a project which was centrally coordinated by for coordinated bioethics education for India. So this was the only program diploma that was available for teaching ethics, and much of it was research ethics. And this was a joint venture between ICMR, that is Indian Council of Medical Research, and the Indira Gandhi National Open University, which was funded by the Fogati International Center, NIH Bethesda, Maryland in USA. Now, what happened is in I joined the UNESCO Chair in Bioethics Haifa, the erstwhile UNESCO Chair in Bioethics Haifa, and now ICP Porto. I joined Dr. Russell in 2013, but he was very much active 5 years prior to that, where he was involved in the UNESCO Chair in Bioethics in Haifa, which mandated teaching bioethics and introducing into the medical curriculum. So when he came to India at that time, I joined him in 2013. This mandate was taken up, and what we realized was there was hardly any ethics teaching in the medical curriculum. So we designed a program which is called the 3T IBHC, which I'll tell you what it is, to train medical teachers and health professionals in ethics and how to teach ethics. Because it's not only introducing it into the medical curriculum, you need teachers to teach ethics. Until date, we have trained about 4,000 doctors, healthcare professionals in how to teach ethics. And under his leadership, we established nearly 80 bioethics units in India. And each unit had a student wing of the UNESCO chair. And we felt the student wing was very important because they were the future in medicine, the medical students. And if we were to change the future of India in terms of providing ethical healthcare, we needed to teach the students also and introduce them to the various ethical values. The UNESCO chair also at that time took up the mandate of introducing bioethics to the private medical practitioners who had no concept of ethics. And this was done in collaboration with the Indian Medical Association, the IMA, and training programs were conducted for these private practitioners, private doctors who were practicing medicine, because they bore the brunt of all the violence that was happening against the doctors. Now, beside training medical doctors, training was also given to nursing, allied health, pharmacy, and dental professionals. And we also had collaboration with the junior medical doctors, the IFMSA, the International Federation of Medical Students, the Association, and Medical Student Association of India. And every year we celebrate the World Bioethics Day to bring the bioethics family together. This unit, now the ICB, spearheaded by Dr. Russell, of course, was able to establish 4 AME centers to take medical education, bioethics education forward. And AME stands for the Association of Medical Educators of Europe. And with them, we've had fruitful collaborations. Currently, we run the diploma and master program in bioethics under the Department of Education, ICB. This was the program that we set out to train all healthcare professionals, teachers, how to teach ethics. And it was called 3T IBHSC. The 3T standard stood for train the teacher to teach and transfer bioethics. So it was not that we kept on teaching every teacher, but any teacher who was trained under this program had to go back to their college and train their colleagues in bioethics. And it was called Bioethics for Human Ethics, Bioethics and Human Rights. And it was called the Integrated Bioethics in Health Science. This was a program, and the mandate was to follow the bioethics co-curriculum, which was introduced by the UNESCO under the 15 principles. And this was a 3-day workshop training all the healthcare professionals, the teachers of bioethics, how to teach and how to assess and how to train other teachers in the various, the 15 principles of the Universal Declaration of Bioethics and Human Rights. And what you see here in the picture are the various institutions that we had the opportunity to go and train. We also had a very active student wing of the UNESCO chair, and students took the lead after hours, especially in my institution in Manipal. We had a very active student wing who would identify ethical issues and discuss it after the class hours. We had a session, and we would invite various speakers, have role plays, debates on various ethical issues. And we introduced a newsletter which is called Bioethica Bites. Right now, under the chair, we have we have a journal which is called as the Global Bioethics Inquiry. And this journal is very unique in that there is a section for students. Any student, any healthcare student can write in this journal. So the opportunity was given to them. And this journal has been going very, very strong. Another thing that we did, if you look at the extreme right of the screen, you will see that we conducted during the COVID time. What kept us all together were the the webinars that we conducted under this chair. We conducted 15. We were successfully conducted 15 webinars on various ethical issues during that time, and some of you would have been speakers on these various webinars. Right now, that is a year ago, we launched the first ever textbook of bioethics, medical ethics, and health law. Because we realized that even though we were training them how to teach ethics, there were very, very few books that could help them or guide them regarding the principles and the various aspects, the theoretical aspects of bioethics. So, during this training, when we were training our teachers, we advocated for a novel horizontal and vertical integrated bioethics curriculum for the medical courses. We published this in Medical Teacher in 2018, which advocated for integrating bioethics into the curriculum in a seamlessly integration, which was horizontally and vertically. And what we said that every medical teacher or any teacher who is in health profession should be teaching ethics, and it should not only be left to the ethicists. Because if you look at the medical teacher, an obstetrician is aware of what are the ethical and legal issues that arise in obstetric care. And who better than to teach it than the teacher in obstetrics and medicine? So it was the same throughout the entire medical curriculum. And in anatomy, when the students come for anatomy, the anatomy teachers would teach about respecting the cadavers, human dignity, human values. This was taught by the medical teacher in anatomy. So this was our suggestion to teach bioethics. Now, during this time, Dr. Russell and I, we had the fortune to meet the president of the Medical Council, the erstwhile Medical Council of India, which is now renamed as National Medical Commission. This Council regulates the medical education in India, and they made a statement for reform when they wanted to reform the medical curriculum. And this was a statement, and I quote, "Teaching and learning of medical ethics, behavioral science, communication skills, and managerial skills have not received due attention in the existing medical curriculum. Hence, they realized that there should be a new change." So the Medical Council of India in 2018, along with Dr. Ved Prakash Mishra, who was the chairman of the Academic Committee of the Medical Council of India, who's also the president of the Association of Medical Educators of India, put out a module, and this module was called the ATCOM module. And what does ATCOM stand for? Attitude, Ethics, and Communication Model. And this model was similar to the vertically and horizontally integrated curriculum, where over medical students had learning modules in professional 1, 2, 3, and 4th year. And they also recommended what are the teaching learning methods and define the goals, roles, and competencies that align with the Indian requirements of an Indian medical graduate. And it also had how the competency can be acquired and how it can be assessed. So this was a comprehensive module that was introduced. Now in India, every medical college, it is mandatory that they have the ATCOM module is being taught to all the medical students. But we know that the world is changing, and we need to continually revise or add or even subtract from the medical curriculum. So we have to be aware that there are advances in technology, there are issues of climate change, the medical science is changing, global thinking is changing, and global policies are changing. So in tandem, we should be able to revise our curriculum or to add on and to remove what is old from the curriculum. So that is what we have to look forward to. This is the last new innovation that we have formed in India. It's called the Beyond Campus Curriculum. So it is an international graduate course on humanistic and socialistic medicine for healthcare providers, and it's provided by the Department of Education, the ICB. And this is a foundation course on moral values, bioethics, professionalism, and personal well-being. And this course has been introduced as a trial in 2 medical colleges currently. And how this course works is, why is it called Beyond Campus? Is because after the regular school hours, once a week, the students have an online class which deals with moral values, bioethics, professionalism, and personal well-being. The teachers are from all over the world. We have international speakers as well as national speakers, and the students are taught over the 4 years. And we've been assessing the students, and overall we have had very good progress and outcomes in this Beyond Campus curriculum. So I will here and say thank you to the organizers, and I would, if there are any questions, I'll be happy to address them. Thank you.
Thank you, Professor Mary. We are going to take questions at the end. We have 2 more face-to-face presentations here. And thank you for that presentation. Yes. I have to add here that this was an achievement of a chair, bringing in by law ethics into the curriculum of the world's largest medical education program. I don't know if you're all aware that India has the largest world medical education program with roughly, I think, 750 medical schools. Second comes United States with 147. So, and they also have the largest reservoir of medical teachers or educators I think 114,000. So this was brought, we were part of bringing this by law into the program, and the Beyond Campus has gone very well. We just presented the data. That's again in tandem with the World Federation of Medical Education. It was a trial program for the first batch, and they're going to finish at the end of this year. Okay, so now we're going to take you on to face-to-face. We have two wonderful presenters here who are with us. So from the Zoom, we'll move here. The first presenter is Professor Paula Castello. Professor Paula Castello is from the Federal University of Sao Paulo in Brazil. And I think she is a dental teacher and takes teaching health professions and also with the research ethics committee. So you're going to talk about ethics committees and the education of bioethics. Over to you, Paula.
Okay. Good morning, everyone. Okay, I was already presented. Paula Midori Castello, Associate Professor and Coordinator of the Research Ethics Committee of the Federal University of São Paulo. Okay, I would like to first present our Research Ethics Committee, our REC Unifesp. It started as a medical ethics committee in 1991, analyzing and judging medical conducts in the context of the hospital, São Paulo Hospital. In 1996, the National Research Ethics Commission, the national one, Brazilian national one, CONEP, was established, and together with the first regulation, 1906. And 2 years later, finally, we established our REC, our Research Ethics Committee, still inside the hospital, São Paulo Hospital, now then analyzing research projects exclusively. We have two former coordinators, Professor Medina and Professor Miguel Jorge. He's also here. And since then, two main regulations were published, the 46.6 and the 510, which support the implementation of projects in the fields of biomedical and humanities areas. And last year, we celebrated the 25th anniversary of our REC, and we have just now a new law for clinical research approved here in Brazil. I forgot to mention then that I started as a coordinator in 2020. We are part of a huge system, the Brazilian system called CEP-CONEP, with more than 800 local RECs. Our REC receives and analyzes more than 110 new projects per month among all the disciplines, the biomedics ones and the humanities. And we currently have 52 members among experts and non-experts. According to our regulation, we have advisory, deliberative, and educational roles whose ultimate objective is the protection of the participant. So the bioethics education should be provided to all sections that interact with us directly or indirectly. By providing bioethics education, we can see various gains. The first one, the most important, is the formative, where researchers acquire important concepts of bioethics. It also reduces the risk imposed to the participant. It improves the quality of the material, the protocols sent to our REC. So fortunately, reducing our work, and finally, reducing the time of the project analysis. Of course, we have many challenges we face every day, such as the constant need for updating regarding values, knowledge, and practices. This is so much dynamic. Our human and material resources restrictions, it's not exclusively of our REC and not exclusively of Brazil, but we see many examples worldwide. The constant changes imposed by the scientific advance, new research capabilities, social media, large data sets, the omics, the pandemic, the new policies and regulations that were discussed these days here. And finally, we should ensure the timeliness of the project review. Talking about the bioethics education we can potentially provide to the community, I can divide it in different levels according to the amount, the depth of information, and also the complexity. So the first one is the education provided to the research participants, that individual who in a free and informed manner voluntarily participates in the research. And I would add that here in Brazil, we are not allowed to pay for participation, so they are 100% volunteer. In 2020, during pandemic, the National Commission proposed this guideline, the participants' book. It is available online. The name is Are You a Participant? A Research Participant, where they can find guidelines, communication channels, they can exchange information, and also the post-study rights. Most of them, they don't even know and should be aware of the access to drugs, therapies, diagnosis, clinical or laboratory results, even after study. Since then, the link of access must be included in the free informed consent form in our university. And also we provide informative material, podcasts, videos, and others in our website, and they can also find in the national website. And I'm happy to say that during the pandemic, the committee perceived that the population's gain in scientific knowledge was huge due to information disseminated in the media and internet sources. The second level is about the students and researchers, those responsible for conducting the research and co-responsible for the integrity and well-being of the participants. I brought here some results from Benin. They conducted a study among 110 medical lecturers and researchers. They performed interviews with them, and the results found were, for example, 69 of the researchers correctly quote the basic principles of Belmont report. Only 25 knew the attributions of the National Ethics Committee. Only 25 present a briefing note about the study to their participants, and 63 systematically request informed consent. One of the reasons pointed by the researchers were the difficulties to explain technical words and the perceived participants' inability to understand the information. And I would say that is particularly concerning in some African countries with a lack of access to health care, a high burden of disease, infectious disease, and some clinical trials are the only opportunity they have to access a healthcare treatment. For this reason, when we have a contact with students and researchers by our reports, project reviews, and lectures we provide to the departments, the graduate courses, we ask them to reflect about the principles of bioethics, to balance the benefits and risks, the autonomy and the right to let the participant choose of accepting or declining an invitation based on their own values. We ask them to reflect about the need to protect and respect the participant and take care of those aspects instead of only focus on the project approval, and emphasize that protecting the participant, the researcher is also protecting himself, and emphasize the process of obtaining the informed consent. This must be a process and not merely obtaining a signed paper. So every opportunity counts in this contest. And the third level is the institution staff and administrators, those responsible to support the research ethics committee, responsible for policy development and or the implementation. And I brought here the case of the Brazilian General Data Protection Law, which was published in 2018, and the use of patient records at our hospital, the university hospital. It is undeniable that patients' records are valuable sources of data, very important for the advancement of the knowledge, the science. However, it contains sensitive information from the patient who provided it for assistance and not research, and which potentially can put him or the patient at risk. The law has entered into force in 2021 during pandemic, and since then, the use of patient data should only be acceptable by obtaining a signed consent form or using anonymization process of the data by the controller. And in this case, the controller is the hospital, not the researcher. And since then, we put a lot of effort, many meetings, hours of discussions around the laws, around the bioethical principles, and used qualified mediation to reach a mutual understanding between the committee, the researchers, and the institution. And among the institution, we have the Data Protection Office with lawyers. So to finally make the rules come into effect. Of course, that these changes were not immediately well received by the community and require the awareness of the respect and dignity and privacy, the right of privacy of the patient. So in the end, we can conclude with this case that institutional governance and policies frame, in the end, they frame the practice of the research ethics. And the last levels are the committee, non-expert, and the expert members who perform the ethics review, ensuring that any project should balance the benefits for the participant or for the society, and the risks, the potential risks, and the committee staff, who is also expert and provides the standard operation procedures, and in the case of the coordination, perform mediations with the researchers, and also provide recommendations for the projects. According to Castro, a study from Brazil, there is a growing concern worldwide regarding the competence and training of our REX members. We perform complex tasks that require in-depth knowledge, not restricted to technical, methodological, or bureaucratic details, but also include many responsibilities, values, and ethical aspects. So that's the reason it's essential to have qualified board members who, in our case, receive specialized training at the beginning on admission and constant updates, but keeping in mind that they are all volunteers. I study from Croatia. They performed a workshop with the ethics committee members from the hospital and interviewed those members before and after the workshop. And most of them told that they feel that their knowledge should be improved by additional education. And also the findings show that their views on certain issues, and when judging projects and when analyzing projects and bioethical dilemmas, displayed a high level of paternalism and overprotection that did not change after the workshop. I would like to also add that our expert members and non-expert members, they are very important as they function as hubs. The hubs here, here, and they connect the community, the students, to our committee and spread the information, the necessary information for the students and researchers. The National Commission identified a need to fix some discrepancies between the analysis between local SEPs, and to fix those discrepancies and update our work. So between 2019 and 2021, the National Commission visited 832 RECs, local RECs, and trained more than 11,000 members. The assessment and training visits focus on different dimensions: the operational one, the administrative issues, so trying to fix some administrative issues, and analytical one, based on ethical reviews. They selected 5 research protocols from the archives and reviewed together with our members and staff, and further classified as full compliance, partial compliance, and non-compliance to the standards and regulations. So highlighting the aspect that must be improved, and trying to find a higher level of consistency. So further suggestions for the research bioethics education, specifically speaking about the research bioethics education. According to Arbrow and Hunter, we should improve the creativity and innovation in bioethics education, focuses on examples of excellent, inspirational science, instead of focus on bad scientists, bad examples, unethical examples. Kiwanuka also said that we should also avoid a disconnect between teaching research methods and bioethic theoretical foundations, trying to find an applied one. And finally, this is a question. Should research bioethics training be mandatory to all students who will start a project, a research project? As the example currently now in Brazil, every student who will start a project on the use of animals must have a specific training before the start of the project. So I would like to thank you all, and this thanks the Scientific Commission.
Thank you, Paula, for that excellent presentation. We've had, talking about ethics, we had a glimpse of bioethics education in India. Now we have just completed a glimpse of research ethics committee education for bioethics in Brazil. So we've completed these two, and now, as you know, we'll have the questions at the end. And now we have our last presentation, and this is, of course, from Dr. Jasna Karacic-Zanetti, who, of course, is from the University of Zagreb. But more importantly, Jasna is the head of the Department of Health Diplomacy and Patient Rights. And I think she's also a faculty member of the Department of Education and does take teaching for the students. And I think she's also with the European Union, based at Brussels, with her health diplomacy. In fact, I didn't understand much about it, but she is an authority on the area of health diplomacy. So she's going to talk to us about education for bioethics as a global endeavor. Okay, over to you, Jasna.
Thank you very much, dear Russell. So, good morning, everyone. And I'm really happy to be here. And as a health diplomacy expert, I know that is crucial to understand how bioethics plays a vital role in shaping global health policies and practices. Education in bioethics not only prepares individuals to address ethical dilemmas in their own context, but also equips them to contribute to international health policy discussions and health diplomacy efforts. I know it very well, especially in the European Union. By fostering global perspectives on bioethics, we can promote more equitable and effective health solutions worldwide and ensure that ethical considerations are integrated into global health strategies and diplomatic negotiations. So I will start with this my presentation, and we know all here, we know the definition of the bioethics, but I'm not sure if we know actually what is the input and output of bioethics. So as you can see here, input is ethical values and moral in the definition of bioethics. But what is the output? Output is ethics and professional education. So that is what we deliver in the practice every day. Bioethics education is crucial for preparing professionals to handle ethical dilemmas in their fields and enhancing global cooperation. Into the rapidly evolving landscape of science and technology, bioethics provide the necessary framework from addressing the complex moral and ethical questions that arise from that. Whether it's a healthcare, research, public health, or environmental science, bioethics helps professionals navigate all these fields and challenges that come with the advancements such as genetic engineering, artificial intelligence, and biotechnology. As our world becomes increasingly interconnected through globalization, the needs from comprehensive and universally applicable bioethics education has never been more pressing as today. Globalization brings with a range of bioethical issues that transcend the national borders, such as equitable distribution of medical resources during pandemic. We saw the situations about distribution of vaccines for COVID-19. It's imperative that bioethics education equips professionals with the skills and knowledge to collaborate across cultural and national boundaries, ensuring that ethical considerations are integrated into global decision-making process. A globally standardized approach to bioethics education fosters a common understanding and respect for diverse cultural perspectives. This is also very important. And to encourage the development of universal ethical principles that can be adapted to local context, promoting a more cohesive and ethical global community. This is particularly important in today's world where decisions made in one part of the globe can have far-reaching consequences in another. Of course, pandemic is one of the best examples. The main authority, for example, is the CDC, Center for Control of Disease, or World Health Organization, or any other. By preparing professionals to think ethically and act responsibly, on a global scale, bioethics education plays a pivotal role in addressing the moral challenges of our interconnected world. The global context, we know that the globalization has created a world where bioethical issues transcend national boundaries. Shared global challenges such as pandemics, genetic engineering, and environmental conservation require a collective approach. And therefore, establishing a framework of universal principles in bioethics while respecting cultural diversity is essential today. Core objectives, we already know, but it's important to say that include the developing critical thinking. This is in my experience, number one, is critical thinking. If we have this, then we have all. Then promoting ethical awareness and fostering global citizenship. Critical thinking allows professionals to analyze the complex ethical issues. And ethical awareness helps them understand diverse perspectives and fostering global citizenship, encourage international collaboration and understanding. Key areas also very well known, but we know that there is medical ethics, research ethics, public health ethics, and environmental ethics are very important, like key areas. Clinical ethics, this is something what we maybe know the most because this is the setting in the hospital every day for clinicians. Involves the ethical issues encountered in clinical settings such as hospitals and all clinics, of course, private and public health. Includes patient autonomy, informed consent, confidentiality, and end-of-life decision-making. Teaching clinical ethics helps healthcare professionals make morally sound decisions when treating patients. Clinical ethics education is a fundamental aspect of training for healthcare professionals, and it prepares them to handle all these ethical dilemmas that arise in patient care. This education is very, very important and aims to develop the skills and knowledge necessary for making ethical decisions that respect patient rights, promote justice, what is also important, and maintain professional integrity. This is some balance between patient rights, patient obligations, and of course, right of the healthcare professionals and their obligations. So this is like a puzzle because it's very important to have a good doctor-patient relationship. Understanding the basic ethical principles is essential for clinical ethics because, as I thought before, it's autonomy that is very important, beneficence, non-maleficence, and justice. Because in the justice, ensuring fairness in the distribution of healthcare resources is very, very important when we talk about bioethics. Then we have something what is very well known. This is informed consent. This is for someone is just some piece of document, but it's very important to know that informed consent is not only sign. It's a document that shall contain all necessary information, and the patient need to understand it, this is the first part of these documents to understand, and after that, sign the document. So please be aware and please take home this message that informed consent is not only paper that is signed from the patient. And then is one question what I have very let's say often in my practice, especially in the work on the ombudsman. If there are cases when we have informed consent signed by the patient for one thing, and for example, during anesthesia, during operation, we have such a situation, a surgeon finds something other that was explained in the. So what is the balance there? What is the harm? Can we do it anyway if we don't have informed consent to, for example, to remove other tumor that is found during operation, or we can just make this surgery as it has supposed to be, and then schedule patients to the new operation, a new anesthesia, and to remove to other one. And this question is really on the court something what is always a big discussion and with the court witnessing, and everything is not easy situation, and it is always part of doctor-patient trust and relationship. So what about privacy? Maintaining patient confidentiality is a key ethical obligation, and training in this area, it's very important that they include understanding the legal and ethical requirements for protected patient information. And of course, navigating situations where confidentiality may be ethically challenged, such as reporting infectious disease. Of course, I will come back to the pandemic and reporting each case that came positive on the test, for example, in the COVID. And that was a very big question in the Court of the Human Rights in the Strasbourg about this right to keep this information hidden from the public, or to give this document like he is that one contagious one positive on the test. So that was a very big challenge to navigate. End-of-life decision-making it presents some of the most challenging ethical dilemmas we also heard before in the presentation about end of the life. And this is very important to communicating effectively with the patients and their families about end-of-life options, especially with the families that sometimes they need to decide what to do for their loved ones. Respecting patient wishes regarding life-sustaining treatments is also very important. I had also several examples about euthanasia, and in some countries where this is possible to do, and then we have countries where it's restricted, and then patients need to travel and to organize all of this process. And now we have also all associations that take care of all this process, from the communicating to the transport to the clinics where it's possible to do. Ethical issues in specific clinical situation, of course, as I mentioned before, in the operating room, or so, we always can have the unexpected situation, and we need to be ready for them. And if we are not ready, that means that we are not very well educated, because it's not everything by the book. So every day in our practice, or in the clinics, or in legal offices, or each part of the professionals, we can have something what is not expected, and we need to be ready. And we can be ready only if we are well prepared for it. Interprofessional collaboration, very important, because developing skills for effective interprofessional communication and collaboration is crucial for this, to understand the roles and perspective of different healthcare team members. As we can see here, how many different professionals are involved in bioethics. And case-based learning, one of the most effective methods of teaching clinical ethics is through case-based learning, to analyze our situation before, or what's happened around us. This is always the best approach. Legal and regulatory aspects also involves understanding the legal framework governing medical practice. Here is very important to know, to be familiar with the relevant laws, local laws, but also very important to know even international laws. For example, about the so in the States, it's health insurance portability, accountability, or general data protection in Europe. They are very, very similar, but of course it's good to know this one, and of course it's good to know any other if exist. Understand the legal implications of ethical decision is also important, and navigating mandatory reporting requirements and legal protections for healthcare providers. There are of course cultural competence, because we know that the different culture can have very high impact of the ethical decisions. Research ethics, something what I really like as a scientist in the background. So research is very important, and as I'm also editor in the PLOS journal, what I can see very often that, for example, we receive the paper, but there is no anything about research ethics, approval of this study or something like that, and it's really something what I'm always really a bit impressed in today's world, that there is still needs be something to refuse the paper or send it back. And so the research ethics is very important, and we should always to keep in mind the guidelines and documents, very important documents like Belmont Report, the Declaration of Helsinki, what we will have presentation later, and government rules, because without government rules, it's very difficult to know what's happening around us. And of course, informed consent, even for research, is very, very important. Risk-benefit analysis and privacy, of course, it's always one of the very important talks. And then institutional review board, because without that, it's very, very difficult to have a real good one research. Ethical issues in specific type of research, we can find it every day. Today, especially when we have artificial intelligence or genetic editing and etc. Animal research ethics, and now we are going to public health ethics, and this is the part what became popular in the pandemic, because before that public health ethics, it was not so superior to the others. Now it is, and now it's like #1. That means that there is no any bioethics under the public health. So that means in the crisis situation, as a war or pandemic, practically there is no any more bioethics. So that means that public health is the #1. It's most important to protect all people on the world, and any law, any legal implication, anything, it's falling down, because like public health, it's the most important, and it comes over all rules, all legal implication and everything. So balancing this individual right with public health is always something to discuss, because anyway, health promotion and disease prevention is something that we need to consider also, to have preventing programs and to stay in this bioethical field. Then we have, of course, some new aspects in the education, like genetic ethics, reproductive ethics. We have also neuroethics, and I'm sure for the next 5 years it will increase, like specialization in each topic in the bioethics. And of course, this one is also very, very important, that include the impact of this medical waste on the environment. For example, in the European Union, this is very popular, like green like medical waste, and it's very common to think in that way there. Then we have, of course, this global bioethics. And something what I also like, and this is the part of the education, and this is professional ethics that involves the ethical standards and responsibilities specific to healthcare professionals, and includes the issues like this professional conduct, conflict of interest, and ethical use of medicinal technologies. And it ensures that healthcare providers adhere to ethical principles in their practice. Something about technology and ethics. We published a paper with Professor Ruinous about debate over digital health information storage in the wallet and the right to be forgotten. It's a very, very interesting thing because there is still no such enough information about storing informations, about if you now came to hospitals and you want that your file and medical records is deleted from the system. Because anyway, if we're going to data protection, each hospital, if you were attended there, so they have your address, your phone number, and all data. So if you came to the hospital and you ask, I want that you delete my file, this is still practically not possible, but this is a thing of the issue. So all bioethics, it's a balanced education. Don't forget to it. There is no unique definition that can apply in the practice. Maybe in the book there is a definition, but that's what we can see in everyday work. We can always have some dilemmas. What is the wrong? What is the right? So universal principles, diverse perspectives is very important to balance, to listen to critical thinking. Don't forget about that. We need to address this. Very important is the importance of this international collaboration. I have very good collaboration with the United Nations, with WHO, and I'm always searching to find a way to address all these issues, what we have, especially in this health policy and health diplomacy practice. It's very important to involve always the representatives of the high level. And promoting human rights and dignity. One part of my department is the patient rights, so I know it very well. Because if we're going to the human rights, then we know that the patient rights is part of the human rights. This is not part of the insurance and the right to have good treatment in the hospital, the right to the medicines. This is the other part. But patient rights, as the self, it's a part of the human rights. And of course, we have for the future into education, despite the progress, there are significant challenges we faced. And I'm sure in the next 5 years, we can have some better impact in the cross future. What do we need actually then? Maybe in this next year, for the next conference, maybe reinforce the significance of integrating bioethics education in health diplomacy efforts. That means, of course, negotiation process. Encourage ongoing collaboration to address global health challenges ethically, effectively. And call to action. Promote international partnership for bioethics education and health diplomacy. That means each of you know at least one person in other country that can share your thoughts or your plans, and so feel free to use it. Send emails to your colleagues. At least they need to know what you do in your department. Of course, we have some examples of good practice, and what we did during pandemic with Professor Russell Souza, we made online program. We shifted practically from in-person program directly to the online, and that is accessible for all world. We also we managed to with the time also to be that is good for all, and it was very interesting. It was very useful, I think, for many participants, and I'm really proud that I was part of this program. And what I can say for conclusion, investing in education is one of the best decisions we can make for a brighter future. By prioritizing education, we empower individuals with the knowledge and skills needed to excel in their careers and personal lives, of course, not only careers, because we know that bioethics touch us in personal level in the same like professional level. Moreover, a well-educated population drives innovations and economic growth, fostering a more prosperous and equitable society. Education investments also helps to break the cycle of poverty, providing opportunities for all, regardless of background. Ultimately, when we invest in education, we invest in potential of humanity itself. And please take home this message. By teaching to others what you are learning yourself, you actually retain information more effectively than by study alone. So, while we teach, we learn, from Seneca. Thank you very much.
Thank you, Jasna. Thank you very much for that presentation. Now, we're going to have questions. Is that right? Okay. As we said earlier, we will open now for a few questions to our panel of speakers from around the world. Yes? Yes. I think, yeah, we'll give, yeah. And we're going to call,
yes, can I start?
Yes.
Yes. I want to ask a question to Dr. Daniela from Israel.
Yes.
Good morning, good evening, or good night, Dr. Daniela.
Yes, afternoon, good afternoon, yes.
My name is Daniel Alvarenga. I'm a medical doctor. I'm a counselor of the medical state of Minas Gerais, and also a professor of pathology at the Federal University. I really, really enjoy your speech. And we share a lot of nice things, starting from our names, right? Daniel and Daniela, which is a wonderful name, right?
Wonderful.
In my first class, when I start teaching pathology, just to tease the students, I tell them, well, I must tell you two secrets. First of all, we don't treat diseases. So the students look at me like I'm crazy. And second, I said, there's no one who calls next. So then I explain, we do not treat diseases. We treat a person who has disease. It's completely different. So when I said, when you treat a disease, you either make a biological mistake or a grammatical mistake. You can choose. Because this is completely different. Right? And when I say there's no one who calls next, because there's no next the Souza, next the Silva, next Smith. There's a person. So when you work, you should call the person by the name. In my questions in pathology on tests, I never ask direct by, oh, there's a breast cancer, tell me the classification. No, I start with the story. There's a person, there's a lady, years old with the cancer. Please tell me the story about, or the classification. So thank you very much for your speech, and we share a lot of things, and I wanted to share this with the people here.
Thank you very much, Daniel.
Shalom.
Thank you.
Yes,
thank you very much for that.
If I may add something to what you say, because you know, I teach at medical schools, and one of the dean enters the first class of doctors. It was at the beginning, and he stood and he said to the doctors, to the new doctors to be, I want to teach you three main things: modesty, modesty, and modesty. And those are these three main things that as human beings, we have to be aware of it. And thank you very much for what you said. Really, very important. Thank you.
Thank you for that. The next speaker. Yes.
Hello. Good afternoon, Dr. Laura. I'm José Rigotti, a medical doctor from Brazil. Teaching bioethics is really not easy. Thank you for your insightful presentation. Considering the importance of both knowledge and empathy in patient care and the genuine valuing of human rights to all human beings, what do you believe should be incorporated into the education of Israeli medical students regarding the Gaza massacre, especially in the light of tens of thousands of children and women killed, the amputations performed without anesthesia, and the destruction of the entire health infrastructure in Gaza? Thanks.
You ask me, so Russell, the question is?
I think the question is, he's spoken about empathy, compassion. Is that right? And how do you teach students with particular reference to what is happening in Gaza, where children are having no anesthesia to have surgery and so forth? Is that what you were? Is that the gist of what you were?
What should be incorporated into the education of the Israeli medical student, considering the fact that are happening in Gaza?
I think that the first thing, it's for me, yes, I cannot hear you so well, so this is the reason that I asked twice. Russell, this is a question for me?
Well, I think what the professor there wants to know is, how do we incorporate this into teaching ethics? Is that into students? Is that right? Yes. Or is it just to students in Israel? Are you talking to students around the world? Well, I suppose it's to every student. That's what he's asking. How do we incorporate this?
Yes.
Well,
Daniela, the question is for you, Daniela. The question is
okay, because I didn't hear it, so I have you. Okay, okay. This is a very, very huge and great challenge. I think that we teach, first of all, to be human beings, because as an Israeli, when I see a small child in Gaza, or I see a woman in Gaza, I have the same feelings. And when we really show some pictures and we speak about dignity, we speak about humanity, we speak about being, first of all, a human being with a lot of passion, and to look at to look also, just a minute, I want to really be very precise, to look at every patient as human being. It doesn't matter if a man, woman, from Gaza, from Israel, from Syria. I teach also doctors all over the world. First of all, the first basis of bioethics, it's being human. And when I see a small child or a woman in Gaza, I feel the same, and we discuss it, and we really define it, and we try to really emphasize our feelings, to define and emphasize our feelings, what I see, not what is politics. We don't really give any place for politics. I teach like this, okay? For me, every human being we will treat on the same way. And I think that our doctors have a lot of passion and a lot of willingness to treat a patient from Gaza. And you know, we have in the hospital, in the Israeli hospital, we have doctors that get, you know, some very bad wounded people from Gaza in Israel hospitals. I don't know if you know it, but we are really dealing with those people as equal, and this is the main things that I can tell, and I want very much that this will be the policy also in the future and in the present.
Thank you for that. Thank you. Well, I guess.
Thank you very much for the question.
Yes.
I think this is to really to see above everything. And as I have told you, the main point is being human. This is the real bioethics.
Thank you. Yeah,
Jorge Santos, pediatric doctor and a student of bioethical doctoral program of Faculty of Medicine of Oporto. About levels of educations, I think you need included the child and the young people. Don't speak here about the child, but the educations can and that precocely. I like the works of Professor Rui Nunes and Professor Ivone Duarte in secondary schools of Oporto with adolescents. It's very important because inclusive education is an ethical imperative. At this moment, the secondary schools and primary schools of Portugal included 30 nationality in large groupments. And I remember Plato, who said, education is very important, particularly if occurred in child, because induce an homework permanent. It is reflections, and you can comment. But I would like to pose a question to Professor Mari Mathieu. You speak about 3T, train, teach, and transfer. And I would like to pose if you, what is your opinion about difficult or not the transfer of bioethics principles, highlight the no discriminations to the human social status for the politics and India society. You understand, Professor?
Thank you. I will try to respond as I understand it. The first thing I want to say, Professor, is that regarding youth program that is run by the ICB, I would like to tell you that we had a training 3-4 years pre-COVID for the teachers of primary and secondary schools. We trained the teachers how to teach them, teach the children bioethics. So we did do a program like that, and we in India the ethics has been introduced not as a word called ethics, but they teach it as moral values. So in schools, the children are taught about moral values. So that is there already. They don't name it as ethics. Now, the second question, if I understand right, you're talking about women and children. And the issues, ethical issues regarding women and children and the Indian society. Now, the Indian society has progressed quite a bit, even though in the rural areas there's a lot of cultural practice. I wouldn't say discrimination, cultural practice regarding women in the society and children in the society. A lot of it has changed. When it comes to research in women and children, there is the rules of the ethics committee stand and the principles of ethics stand. There is no discrimination because they are a vulnerable group. in fact, there is more overprotection for these groups than the standard regular participants in the study. Now, in the Indian society, I'm not sure in what context, Professor, you have said, what is it, the cultural issue in the Indian society or the political? Because in politics, there is no differentiation between a man and woman. There's equal equality in terms of, there's no discrimination in terms of jobs or religion. But I'm not sure what is portrayed outside globally to the world regarding the Indian society. As such, the society respects women and the values that, the family values that are inbuilt within the cultural Indian society. I hope that answers your question, if I've understood right.
Well, I can tell you that one part of it was about schools that you were doing in Porto or in Portugal. We have a program, a school program in the erstwhile UNESCO chair. Merka, Professor Dr. Merka used to head that program, and if I remember right, Amnon Kami's wife was one of the portrays of that school program. And we, as Dr. Mary has said, we actually launched this program in India. I still remember it was the same day as Trump had visited India, so we had to put, all the roads were blocked and all that stuff. So it was launched there. Again, there's a good book format that Professor Kami and Merka and others put together, which we were taking out in the form of stories and so forth for school, both primary and secondary school. So we did have that program, and certainly that was launched in India.
Sorry, can I add something about the program for children?
Sorry?
Can I add something?
Yeah, what's your question? Sorry, you want to ask a question, Daniela?
He wants to add something, Professor Russell.
You want to add something, is it? Yeah, go ahead. Daniela, do you want to add something?
Yes, I wanted to add something. Yes, I wanted to add that about the program, about the children, we developed together with Mirka Bashinova, if you remember, a very nice program to teach bioethics from the age of 5 years old, from kindergarten, through stories and didactic tools from children from the age of 5. And we train, we train the teachers from the age of 5 till the age of 19 how to teach bioethics from kindergarten to high school. We have a whole program and we're teaching it.
That's what I was just referring to, a program that was initiated during Professor Kami's time, and I was part of that. Mirka was leading that.
Yes, also. Yes.
Yeah. Any more questions? Yes, sir.
Good morning. My name is Jordan Araújo. I'm a medical doctor for more than 35 years. I'm a surgeon and I teach medicine and other health professions for more than 30 years. So I'm an old man with an even older mind. And I'd like to whom feels like answering. I perceived during these last decades, since the advent of social media, very, let's say, complicated ethical behaviors by students and professionals with publication of surgical procedures, publication of stories, names of patients, and other situations which are very embarrassing, at least for me, which I am an old man. And I'd like to whom feel answering, is this a worse word for ethical behavior, or I'm wrong? Thank you.
Who wants to?
Can I answer first?
Yes, go ahead.
Can I answer? Yeah, so Professor, we had a problem when our first year medical students came in. They used to click pictures of the cadavers and, the dead body. And we were we were against it. We advise the students when they come in now in first year itself, we advise them certain do's and don'ts of what they can do regarding social media. Our university has made it a policy that nothing from the university, from the medical school will go out without the permission of the university. So if you're putting anything on social media, Facebook or Twitter or what, X or wherever, you require the permission of the university to do that. So students are not, also many of our students start blogging. Their first day in medical school, they start blogging. Now, all that we tell them, the university has a policy regarding this, and they're not allowed to do that. So for us, it's very clear. We tell the students upfront when they come in.
Is there one more question? Is it someone? Ah, yes. Go ahead. Who's that? You given the mic? Yeah, go ahead. Yes, sir.
Yes, Russell.
Yes.
I am Mirka Vashinova. I confirm that our
I
unit...
don't hear Russell. So
yes.
I cannot hear you.
Yeah, Mirka's a bit soft. Yes.
Mirka is speaking. Mirka.
Yes, shortly. Daniela, thank you that you remember first syllabus that will be done by our unit, Italian unit, with some experts of our chair. We have 2 editions, and when you do you like and other specialized people in this matter, we will be very happy to prepare and to finish 3rd edition. Thank you.
Thank you. Thank you, Mirka.
Mirka, yes. Dear Mirka, I'm very happy to see you. I'm very sorry that I cannot hug you because it was a problem to go out from Israel, for me. But I will do it with pleasure with you, and to finish the 3rd edition and really to give, those children the basis of living in a better world and teach them the language of ethics and bioethics. Thank you very much.
Thank you. Was there one more? Yes, please go ahead.
Hi, my name is Rafaela, and I'm a medical student from Brazil. And my question can be answered by any of the speakers. So I was wondering, how can we, as medical students, be prepared to deal with problems involving bioethics, considering we don't learn about this topic appropriately during our graduation?
We'll give it to them, but before that, let me tell you, please join. We have an international student association, and you'll be more than welcome to join this from around the world. And I think we had one meeting in Croatia, and currently the president is from northern Iraq. So I'll give you the details. Yes, Dr. Mary, do you want to?
Regarding the students, okay. So now in India, all medical students have to go through the ethics course, so they are aware of it.
No.
One thing we did do when we started with the UNESCO chair in bioethics is we formed a student wing of the UNESCO chair.
Yes, that's
and the student wing used to take all the ethical issues that they face during their practice or their rounds or during their clinical years and bring it to the forum and discuss it. And we used to get experts to talk about it and how to deal with it. What Dr. Russell said is we have collaboration with IFMSA, the International Federation of Medical Students Association. We have with the Medical Student Association of India. We have association with many other medical student organizations. So you're welcome to be a part of it. And there are very interesting lectures and debates going on among students regarding all bioethical issues. I totally agree that students are not ready. If they're not prepared, then they're not ready to face the ethical challenge.
Dr. Lincoln
I want
Lopez
to say
was,
something.
yes, he has nominated from Brazil. I think you are the president of the Brazilian Medical Association. He's part of our program. And so we will be happy. There is a program on the 22nd of September called Ethos. It goes on every year. This is the 8th. It's a student conference. It happens every year, usually every year. And you'll be more than welcome to join and take part. Dr. Willington will tell you he helped. Yes, sir. Can we go ahead?
Okay.
With
Thank
your...
you. I'm Antonio Lil. I'm a professor from physical education teacher in the background. Now I'm a medical doctor from physical education and sports medicine and whatsoever. And I would like to present you one poster, it's a project concerning child education and inclusion that means that puts in the center of this poster where are included notions about nutrition, exercise, behavior, cardiovascular prevention, a child that is an amputated child of a leg. We're going to have many children with traumatized after the war and from other reasons. So this is a very inclusive, if you want, model, a new model of education that can be applied to professors, to teach professors at the school level, so they can teach these notions of inclusion, of nutrition, global health, to the students. And that is the main point of this poster that I call Vita Balance Med, for medical. So I would like to challenge Dr. Souza and his Department of Education to bring up this model as an international chair of bioethics models, if you agree, after appreciating it, to use it and try to change at the level of the schools, the primary schools, the notions about education and inclusion of young children. Thank you very much.
Thank you very much. We'll certainly take that forward. We'll talk more about it to you, and it will have a role for that, I'm sure. So can we have the last question now before we close this session? Is that someone? Who was it? So who? Yeah. Oh, yes. Go ahead.
Ele vai fazer a pergunta em português e ela vai traduzir para o inglês, ok?
Ok. Desculpem não falar em inglês. Eu sou o Dr. Mário Viana, sou cirurgião, sou o presidente do Sindicato dos Médicos do Estado do Amazonas e a minha pergunta vai para qualquer um dos palestrantes que se sentir à vontade para responder. Alguns de vocês, e acredito que a plenária aqui toda, tomou conhecimento durante a pandemia da crise do oxigênio que ocorreu no meu estado, maiormente na capital, mas em todo o interior do Amazonas também. Nessa crise do oxigênio, pelo menos 100 pessoas morreram diretamente pela falta do oxigênio, centenas tiveram que ser transferidas para outros estados brasileiros por conta da falta desse oxigênio, além também da falta de vários insumos, como enoxaparina, um anticoagulante, que é um dos possíveis tratamentos na fase de complicação da Covid, e tudo isso foi denunciado por nós no Amazonas e a nível internacional. No entanto, nenhuma autoridade brasileira ou do meu estado foi responsabilizado por esse triste episódio. Eu pergunto, como vocês veem essa situação? O que vocês esperam das autoridades brasileiras nesse caso?
Can you hear me?
Yes. Yes.
The doctor is telling you about a specific episode that occurred in Brazil during the COVID pandemic, especially in his state, one state of Brazil, Amazon. And he said we had a problem there with we lack oxygen for many patients, and they reported to all organizations in Brazil the problem and did have an answer, an effective answer. And he is asking, what do you think that maybe international organizations may make a statement about this episode in many cases of bioethics aspects, like many people has died, 100 people at least, and many of others have compromised their health in a way that maybe not be recovered.
Well,
any of the speakers can answer, please.
Well, we certainly understand, and I think that is an important issue, and this happened in many parts of the world. And I think it's very sad that happened, but this seems to, the pandemic did bring with us many of these issues that ultimately ethics has come. As you might remember that ethics post Nuremberg was focused a lot on consent, on but what we learned after the pandemic, that another important issue was access. How do we share? How do we access? And certainly what you say is very important, and many regions, many countries faced this, and many people lost their lives, including many doctors, particularly in Brazil too. So what you have said is certainly very important, and I take it that all of us here and all the international chair and all the others will certainly be looking at a bioethical statement coming out from what did we learn from the pandemic, and how has bioethics actually changed, or at least the focus had changed to cater to the effects or the implications or what we learned from the pandemic, sadly, at a cost of many lives. Thank you very much for that. And ladies and gentlemen, I want to thank all of you for patiently sitting through this wonderful program, or at least session that we had. I want to thank the speakers from India and Israel and Germany, and here Dr. Jasner and Dr. Paula from Sao Paulo. So thank you all for your contribution to making this an excellent session. And once again, all of you, thank you very much. And we break and finish this session. And I invite you to have your tea. Is it a tea break, isn't it? And come back after that. Over to you.
Thank you to our speakers for their insightful presentations.
Yes.
We will now take a break.
Bye-bye.
Coffee is available in front of the auditorium and upstairs. Tomorrow, the Tourism Secretary of Federal District, Setor, will offer a special tour in Brasilia. Interested parties should look for the Setor stand next to the accreditation. We will continue at 11:30 with our next session. Enjoy your break. your seats as we are about to begin in the World Medical Association session on the Declaration of Helsinki Revision. We now invite the following participants to the stage. Professor Rui Nunes, head of the International Chair in Bioethics, will be the chair of the session. Dr. Ottmar Kloiber, Secretary General of the World Medical Association, to moderate the session. We also invite to the stage our three distinguished speakers. Ramin Parsa Parsi, who will present the introduction to the Declaration of Helsinki. Jack Hesnack, who will talk about the current status of the revision process. Dr. Hesnack is joining us remotely via Zoom. Florentino Cardoso, who will discuss about the Latin America perspective on the Declaration of Helsinki. Additionally, we ask Dr. Miguel Jorge to comment the session. They will provide an evaluation of the new version of the Declaration of Helsinki. We now hand over to Professor Rui Nunes as chair the session.
Good morning to all of you. I hope that you are enjoying this 16th World Conference on Bioethics, Medical Ethics and Health Law. Now we are going to promote a panel from the World Medical Association, and my warm greetings to Dr. Ottmar Kloiber, that will be the moderator of this session, and to the World Medical Association, that is a full partner of this conference. And indeed, without this partnership, this conference is not what it is today, and I hope in the future. We are going to approach the new version of the Declaration of Helsinki, that, as you know, in many countries is the fundamental instrument that regulates human research. And so, of course, it's very, very important that the bioethics and biolaw community have knowledge about this new version, and also to make suggestions so that this new version, that as far as I know will be approved in October by the General Assembly of the World Medical Association, can be even better than it is today. So thank you very much for your presence, and now I will hand over to Dr. Ottmar Kloiber, and thank you very much again.
Thank you very much, Rui, for inviting us to have this session here with us. It is already a tradition that we have sessions on our policy projects with this conference series, and I'm very happy that now, again, we can have a session on the Declaration of Helsinki. The current version of the Declaration of Helsinki is called the Fortaleza version. That is not because there are nice beaches in Fortaleza, it is because it was decided 2013 and adopted 2013 in Fortaleza. Now, we have a tradition that we revise, and Dr. Resnick will speak a little bit about this process, how that is being taken part and has been unrolled over the past years. But I would like to stress at this moment our gratefulness to our colleagues here in Brazil, not only here at the Council, but also at the Brazilian Medical Association, because you have given us the chance to have many of the discussions here on your continent. And indeed, there is no other country where so many discussions have taken place on the Declaration of Helsinki than Brazil. Now, in order to help you a little bit understand what we are talking about, and I guess some of you are familiar with the Declaration of Helsinki and may even use it in your work, for instance, in Ethics Committee, but for all of you, we have asked Dr. Ramin Parsi to give an introduction to the Declaration of Helsinki and a little bit a review of what has happened so far in the last 59, now 60 years of the Declaration. Ramin heads the International Department of the German Medical Association, and not only that, he has previously led the revision of the 2013, the Fortaleza version, so he is best positioned to give you an insight on the development of the Declaration of Helsinki. Ramin, please go on.
Thank you, Ottmar. Thank you very much, and thank you, Professor Nunez. I would also like to thank the organizers for giving me this opportunity to give you a quick reminder on what the Declaration of Helsinki is, what its history is, the principle, the main principles, and its relevance. And Ottmar, I really like the term, the Fortaleza version, because indeed it was in Fortaleza, and this is my conflict of interest, because back then I was actually heavily involved in the revision process, and I'm also currently a member of the work group that revises the Declaration of Helsinki again, and in these capacities I got travel grants from the WMA to attend conferences such as this. But let me start by asking you a question. I would assume all of you know the Declaration of Helsinki, right? Who knows the Declaration of Helsinki? Please raise your hand. Okay, I see many hands, and I want to see the hands here too. You should know that. Okay, I expected that. But now show me again your hands. Who knows it because it's a literary masterpiece, because it's so beautifully written and so nice to read? Okay, I suspected that. There are no hands above, because it's indeed true that the work groups that revised the Declaration of Helsinki, for them it was always important that the language is very concise and clear, and that has always given priority over any beauty of the language or any literary value. Now, the Declaration of Helsinki is indeed considered as a core document of the World Medical Association. It's probably the most known and widely used WMA document worldwide, and it's indeed regarded as a cornerstone document of research ethics. And the DOH addresses the same core issues that are at the very heart of why the WMA was initially established. The WMA was established in 1947 in the aftermath of the Second World War and some of the most horrific ethical failures of physicians that occurred during that time. And it was set up to reaffirm the norms of medical research and practice that must apply to all doctors, and to prevent breaches of ethical conduct among physicians in the future, but most importantly, to re-establish trust among patients for physicians. Now, there are 3 documents that outline the basic ethical principles for physicians in both the clinical and the research settings. First of all, there's the Declaration of Geneva, and we have referred to that a couple of times during this meeting. It's the physician pledge. adopted in 1948, and based on that, it's the International Code of Medical Ethics, which was approved by the WMA General Assembly just a year later. It's the foundation of ethical principles defining the professional duties of physicians. And then, of course, for the research, there is the Declaration of Helsinki, which was actually approved a couple of years later in 1964 and most recently revised in 2013. And as already mentioned, it's currently undergoing another revision process. Now, the DOH addresses a challenge and a conflict that may arise between two key aspects of medical research. On the one hand, the fundamental obligation of physicians to do no harm. And then on the other side, the essential need to ensure the efficacy and safety of medical interventions by testing them on human research subjects. And the DOH sets the tone right in the beginning. The primary obligation of the physician is to the patient. And it continues by referring to the Declaration of Geneva. The health and well-being of my patient will be my first consideration. And it goes on, it is the duty of the physician to promote and safeguard the health, well-being, and rights of patients, including those who are involved in medical research. And in another paragraph, while the primary purpose of medical research is to generate new knowledge, this goal can never take precedence over the rights and interests of individual research subjects. Now, a little disclaimer here, this is the current wording of the Declaration of Helsinki, the Fortaleza version, right? So as we already mentioned, the DOH is undergoing revision right now, and some of this language might be fine-tuned, and there will be a new version from 2013 now. Now, what are, from October on? Now, what are the key principles? Respect for patient autonomy, the careful assessment of risks, burdens, and benefits, scientific requirements and the requirement for research protocols, provisions for research registration and publication and the dissemination of results, and the protection of the privacy of research participants and the confidentiality of their personal information. And then in 1975, the need for approval by ethics committees was introduced, which contributed to the development of research ethics committees in many countries. And the rules were even tightened in 2013 to state that these committees must be transparent and their members duly qualified. Then there are a couple of paragraphs dealing with the requirements for informed consent and procedures for individuals who are incapable of giving informed consent. And these paragraphs have been reworded and fine-tuned over the years and the different revisions in the past. And then there are the requirements to seek consent for the collection, storage, and reuse of identifiable human material or data. And that paragraph was extended in 2013 to cover biobanks. Now, this, of course, doesn't completely and comprehensively cover all aspects and challenges that are coming with biobanks. And the WMA has a separate document on this matter, the Declaration of Taipei. And the current work group also discussed how this wording in the current version of the DOH could probably be fine-tuned to refer to the DOT or make it a bit more comprehensive. And I'm sure that Dr. Jack Resnick will elaborate further on that. Now, there are a couple of paragraphs that have always been a little bit more controversial, that have been intensely discussed over the years. There is, for example, the paragraph on the specific protection of vulnerable groups, which was expanded in 2013. It now includes a stringent set of conditions. Medical research with a vulnerable group is only justified, and then there are three conditions. The researcher is responsive to the health needs or priorities of this group. The research cannot be carried out in a non-vulnerable group, and this group should stand to benefit from the knowledge, practices, or interventions that result from this research. And this paragraph has been heavily discussed during the past revisions, but also during the current revision, and the WMA put a lot of effort into this to make it as optimal as possible to cover all the different perspectives from around the world, and we had even dedicated conferences this year to deal with this subject, and again, I'm sure Jack will elaborate on that. There's a paragraph on compensation, which has also been discussed controversially in the past. A paragraph was added in 2013 stipulating that compensation must be provided to research participants who are harmed as a result of participating in a study. Now there's the subject of post-trial provisions. And of course this subject in this paragraph has been controversial ever since it was introduced in 2000. And it's on post-trial access to the best proven prophylactic, diagnostic, and therapeutic methods identified by the study. This paragraph was introduced to ensure access to the prophylactic, diagnostic, and therapeutic methods that were identified in the study. This came in 2000, but then in 2004, the WMA added a note of clarification and extended the access to other appropriate care. 4 years later, in 2008, the note of clarification was removed, and the wording was taken on in the main document, but another word was added to the access provisions. Now, access to intervention identified as beneficial in this study or to other appropriate care or benefits was added. So it became a little bit more vague, the wording. But then in 2013, the last version, the current version, this paragraph now clearly states that participants are fundamentally entitled to access interventions identified as beneficial in the trial. So there was a step back again, and the paragraph was tightened a lot. And it was also added that this information must also be disclosed to participants during the informed consent process. And then there is the placebo paragraph. And you can probably imagine this has always been a very controversial paragraph. We had a couple of conferences on this topic in the past. I distinctly remember some very interesting conferences we had here in Brazil, and I'm sure our colleagues here remember that too. Very good conferences on a very high level. And the 1996 and 2000 versions of the DOH actually introduced a wording saying that placebo may be used as a comparator when no proven intervention exists. So this is how it started in the DOH with this wording. And then in 2002, again, a note of clarification was added by the WMA saying that placebo-controlled trial may be ethically acceptable even if proven therapy is available if two conditions are met, namely if there are compelling and scientifically sound methodological reasons or if patients would not be subject to any risk of serious or irreversible harm. So back then, these two conditions were linked with an or. A few years later, in 2008, this note of clarification was removed, and this wording was then changed and put into the main document, and the two conditions were linked with an and instead of an or, which of course added additional protection for study participants. Now, placebo would be acceptable when proven interventions does exist, only if there are compelling and scientifically sound methodological reasons and if patients would not be subject to any risk of serious or irreversible harm. And then this sentence was also added, extreme care must be taken to avoid the abuse of this option. And as you can imagine, this paragraph has also been discussed during the current version, and Dr. Resnick will surely say a few words on that. Now, in the 2013 version, the 2008 wording was almost identically taken on again, but it was extended to the use of any intervention less effective than the best proven one. I'm not going to read the entire paragraph now because it reflects sort of the wording from the 2008 version. And here on the photo you see when this DOH version of 2013 was adopted in Fortaleza in 2013. Now, let me finish with a few more words regarding accessibility and usability. The DOH was written and is written by physicians. So it's firstly and foremost a moral obligation for physicians. Although the WMA has always invited other healthcare professionals, other researchers to adopt these principles. The DOH has served as a basis for the development of other international guidelines, so other regulations do exist, but they have a different historical context and also a different mission. Still, the DOH does exert considerable authority upon national and international legislation, and in some cases, it has also been codified into law. A key feature of the Declaration of Helsinki is that it's not a detailed rule book, which some other guidelines are, and they have their specific purpose. No, it's not a detailed rule book, but it rather provides a concise set of easy-to-read ethical principles. Because the usability aspect and character of the DOH has always been very important and has always been retained and enhanced during the several revision processes. And the DOH underwent a couple of revisions because it has always been considered a living document to account for the new ethical challenges presented by changes in the methods and scope of medical research. And I have listed here all the years with rather major revisions in 1975, in 2000s. I mentioned the clarifications in 2002 and 2004. And then the 2013 version, the Fortaleza version, was also a rather major version where it was also completely restructured. It got a new structure, the paragraphs, and currently it's also being revised. And I'm looking forward to Dr. Resnick's presentation. During all these processes, we had a number of international meetings, expert meetings, and public consultations, and I'm pretty sure that many of you also participated in the public consultations in the past and in the current one. Now, I would say the DOH has more uncontroversial than controversial aspects. However, of course, conflicts will inevitably exist. For some researchers, for some people, it is already too restrictive, while for others, it is far too liberal already. So I assume the conflicts will resist, but it is rather uncontroversial with most of the paragraphs than controversial. But the DOH remains at the forefront of providing ethical guidance from biomedical research. And with that, I would really like to thank again the organizers, and I would like to thank Dr. Kloiber the Secretary General, and Dr. Jack Resnick, who is chairing the current work group and who is doing really amazing job to guide us through the whole process. It's really not an easy task, and Jack is doing a wonderful job. So thank you very much for your attention.
Thank you. Thank you very much, Ramin, for this introduction. And indeed, the 2013 version, the Fortaleza version of the Declaration of Helsinki, for the time that I can overlook, and this is now more than half of the history of the Declaration of Helsinki, has been the most stable and uncontroversial version. You have seen there have been different steps in the development of the Declaration of Helsinki, as Ramin mentioned, with some of the core achievements that the Declaration of Helsinki has brought. In the beginning, the informed consent, the first time in an international document being asked for. 1975, the mandatory challenge to have a consent of an ethics committee. Later, the inclusion of the demand for publication and registrations. All those points the WMA has not invented. There were countries which had them before. There were clinics which had ethics committees before. But what we have done is we have made it an international standard. And those principles came on a new level with the Declaration of Helsinki. And I think this is the real value of the Declaration of Helsinki. Now, when I say the 2013 Fortaleza version is a very stable version and the least controversial, at least the least controversial that I know, and as I said, I can overlook quite a time of the use of the Declaration of Helsinki. So why are we going into a revision? Now, the world is developing and health research is developing. One part has already been mentioned, that we had to branch off from the Declaration of Helsinki, that is the use of data and biobanks for research, which need some special rules and requirements, which we have coded down in the Declaration of Taipei. But then how we do research, what are the methods for research, has changed as well. And the social sphere in which research is being done has changed as well. And those were finally the things which have made us taken the decision to go into another revision cycle. And as the World Medical Association is a membership organization, we are very much depending on the willingness of our members to take a large part of this work of development, of rewriting, of discussing, of hearings into their hands. And I'm most grateful that this now has been done by the American Medical Association and the then president, Dr. Jack Resnick, now past president of the World Medical Association. And Dr. Resnick is professor for dermatology in California. He is also our chair of the Finance and Planning Committee of the World Medical Association. And Dr. Resnick has taken it on his shoulders together with his team at the AMA to go into this process of revision. And you will see that this is really a big task with a lot of work, a lot of discussion, a lot of travel, and a lot of meetings around the world. Dr. Resnick, the stage is yours.
Thank you, Dr. Kloiber, for the kind introduction and for your leadership of WMA over the years. Dr. Parsi, thanks for the great presentation and the wonderful context. And thank you all for the invitation to join you and for putting up with my virtual attendance from afar. My apologies that I can't be with you in person, but I am looking forward to, over the next few minutes, sharing a bit about our current revision process. Hopefully you can see my slides. And I'll try to be brief and give a high-level overview because I'm very much looking forward to Dr. Cardoso's presentation, and also I can stick around for some questions. And one of the great things about this process has been all of the feedback we've gotten during regional meetings and from public comment periods. And so we learn at every opportunity that we have, and meetings like this are a great opportunity as well for us to hear from bioethicists and from the public as well. So you heard a bit from Ramin about how the Declaration of Helsinki is a living document and a sense for the revisions and additions over the years. And Otmar just raised sort of the important question about if this is a core ethical document, and many of our fundamental ethics as researchers and physicians and medical professionals should be constants and high-level standards. Why do we need these revisions every decade or so? And as Otmar just said, we have discovered over the years a couple of things. First of which is there sometimes are harms that previous versions have not addressed that we see happening out in the world. So as you look back over the years, whether it's for decades, the lack of an ethics committee being required to have somebody other than the researchers responsible for reviewing research protocols, whether it's the abuse of placebos that we have seen in other decades, vulnerable populations being abused in various ways. So first of all, we have these harms that were not addressed that need to be addressed. And secondly, there are new risks that evolve in a new world. And so, for example, in the last decade, with the emergence of big data and artificial and augmented intelligence, we've certainly seen new risks to confidentiality from our patients and research participants. Environmental sustainability obviously has come into our conscience more and more in the last few years. So things do turn up that we decide that we do need to address in the document, and that's why I think it's only gotten better and better and better with these revisions, and why we are continuing in that tradition with the 2024 version that we're working on. This process has been already going on for more than 2 years. The World Medical Association Council, which really functions like the board of the World Medical Association, established the working group that Otmar mentioned back in April of 2022. And we have really worked to make this an inclusive process with opportunities to contribute around the world. Since we, or you all, are in Brasilia right now, I do want to highlight and thank our 2 Latin America-based members of our diverse working group, Carlos Serrano, representing the Brazilian Medical Association, and Alarico Rodriguez, representing Uruguay, have both been outstanding members of the work group who have brought a lot of fantastic input to the discussions. A second piece of this process, and really the core piece for us at the World Medical Association, has been this series of regional and topical meetings that have been held across the globe to gather feedback. And this is really where 2 things happen. A, where we hear about which sections of the declaration are primed for revision, and debates take place and fantastic discussions around those potential changes. We've had regional meetings already in Tel Aviv, and each of these really is focused on a topic. The Tel Aviv meeting was focused on the implications of big data and machine learning and artificial intelligence. That was followed by a meeting in São Paulo, Brazil, focused exclusively on ethical considerations of the use of placebo and that paragraph and its controversies, as you heard about from Ramin. We moved on next to Copenhagen, where we talked for a couple of days about emerging trial designs and whether new approaches to clinical trials and research, branch trial design, et cetera, required changes to the declaration. We met next in Tokyo, and the Tokyo meeting was focused on research during public health emergencies and pandemics. This felt particularly important in the wake of COVID. Our next meeting was at the Vatican, and you'll notice that these next 3 meetings in a row really were all dedicated to discussions of various aspects of vulnerable populations. So the Vatican meeting was focused on research in resource-poor settings and issues of global justice. Our next meeting in Johannesburg on community inclusiveness, post-trial access, and issues of vulnerability. And in Munich, we spoke about specific and particularly vulnerable groups. We do have 1 meeting left. It is in Washington, D.C., and next month, August 15th through 16th. Would welcome anyone who can make it. And that is really going to be our final consolidation meeting and our talk about plans moving forward as we prepare to meet actually in Helsinki for the 60th anniversary and consideration of adoption of the next set of revisions. And we've also had 2 wide open public comment periods. This is a bit different than in the past. In order to really maximize opportunities for public input, we did this in 2 phases, with proposed changes coming out from the work group in one phase that really occurred back in February, and a second phase that just occurred earlier this summer in June and July to get public comment. And we were thrilled with just the volume and the thoughtfulness of public comments that did emerge. So I'm not going to dig into the detailed wording, given that we're already a little bit behind, and I really do want to preserve time for discussion, but I just want to give you a sampling for some of you who may not have seen the public comment documents that went out of some of the themes from the work group proposals for revision that have been put forth now in 2024. And again, this really has been informed by feedback from the regional and topical meetings and from the public comment periods. So I'm going to take it by section of the declaration, and I'm going to start with the preamble, where some fundamental changes have been proposed. The first one is really to replace the word subjects, which in today's world is viewed as somewhat paternalistic, and change that word subjects to participants, really out of respect for the rights and the agency and the importance of those individuals who take part in medical research studies on human participants. And we did that throughout the document as those words appear numerous times. The second is just a written recognition that those participants can include both patients who have an illness as well as healthy volunteers. And as Ramin mentioned earlier, this is a document that is created largely and overseen by the World Medical Association, a group of national medical associations made up of physicians. And it is, and the previous versions have, of course, mentioned the importance of these rights, but we added language, or proposing to add language this time around, that because these principles are so fundamental to respect for and protection of all research participants, that we are taking a stand that these principles should be upheld by all individuals, all teams, all organizations involved in medical research, and that it's not just speaking to physicians. In the general principles section, a number of things have come up that have led to additional proposals. One is the importance of medical research taking place in the context of structural inequities, and therefore the need to consider how the benefits and risks and burdens are distributed. This is really an issue of global justice, and there's proposed language around that. Also discussed meaningful engagement with potential and enrolled participants, and especially their communities, before, during, and following medical research. Talked about the purpose of medical research, including advancing individual and public health, not just coming up with treatments for disease, but making sure that we advance the health of nations and of the world. Talked about, and as I mentioned, this was the topic at the Tokyo meeting, how essential it is to uphold the Declaration's principles during public health emergencies, and that there's not really a waiver of the Declaration of Helsinki during public health emergencies, while things may need to be sped up, and while innovations in how research is conducted and reported are important during emergencies like the COVID pandemic, that the principles still are the bedrock of participant protections and are so critical to the future trust of the research enterprise. We've added language around the inclusions of ethics review in all countries where international research is conducted, so that if especially clinical trials are being conducted across international borders, that ethics committees, both in the originating country and in host countries, are critical, and have added proposed language around avoiding or minimizing environmental harm through the research enterprise and promoting environmental sustainability. In this section on vulnerability, we've actually proposed substantial changes. We heard a lot in the Johannesburg meeting about recognizing that individuals and groups and communities can experience vulnerability due to factors that can be fixed or contextual and dynamic, and that even participation in a trial or study itself can put somebody who's not previously in a position of vulnerability into one. And then a lot of talk in Munich about balancing the protection for those experiencing vulnerability without depriving them from the important benefits of participation in research. This has really been talked about around the theme of responsible inclusion. And there were so many examples shared about where exclusion from medical research has perpetuated and actually exacerbated vulnerability and disparities. We think about the lack of data, for example, on various drugs and interventions and their effectiveness on pregnant women, for example. But there's also great recognition that those experiencing vulnerability do need special protections and that there are particularly vulnerable groups, for example, let's say the incarcerated, where retaining additional protections is critical and language is being kept regarding that issue. Around scientific requirements and ethics committees, we added language on the importance of scientific rigor to avoid research waste, and the need for ethics committees themselves to have adequate independence and authority to resist undue influence, to make sure that they're adequately resourced. We see ethics committees in some areas asked to do enormous work and very critical work without the resources they need to do that work. Making sure that the membership of the ethics committee has adequate education and training and qualifications, and importantly, diversity among its members. We've had discussions recently about adding specific language potentially around patient or community members as well. And then a recognition that the current language doesn't explicitly state that ethics committees have the authority to withdraw approval and suspend ongoing research. A few other principles, and this is the last slide really on changes. Ramin talked about the Declaration of Taipei, but we felt it's very important to have language specifically in the Declaration of Helsinki, not only about biobanks and human materials, but informed consent for participants in research for the collection and the storage and the foreseeable secondary use of identifiable data, and actually calling out re-identifiable data, as we've seen in the last few years that de-identified data sets, thanks to today's technologies, can unfortunately be re-identified at times. We're maintaining strong language about limiting the use of placebo or use of no intervention or control groups that use anything less than the best proven interventions. Actually strengthened language about the importance of post-trial provisions. And finally, a bit of a rewrite of the paragraph on unproven interventions, which we saw misused in some ways during the COVID pandemic, as though the DOH were granting permission for interventions that had actually been proven not to be helpful, and instead really focusing on how the use in individual patients of unproven interventions, sometimes through compassionate use, should never be undertaken to circumvent the protections for research participants that are found in the Declaration. So I really look forward to Dr. Cardoso's presentation, and I will stick around for the discussion and look forward to questions and feedback from this group. As I mentioned, we do have this meeting coming up in August in Washington. Would welcome additional participation in that meeting. Thanks again so much for the invitation to be with you virtually, and I will turn things back to Otmar at this point.
Thank you very much, Jack, for your presentation and all the work you are doing. And please stay tuned with us because we would like to have you in the discussion after the next presentations. Now I have the pleasure to present you the man who made it the Fortaleza version, because he invited us to Fortaleza. And as I said before, Brazil has been a place where we had a lot of a discussion about the development of WMA policy, and especially the Declaration of Helsinki. But when he, Florentino Cardoso, was president of the Brazilian Medical Association, he said, wait a minute, it cannot be everything in Sao Paulo and everything in Rio, and you have to come to Fortaleza. And we had a General Assembly in Fortaleza, which then gave us also the Declaration of Helsinki. Dr. Cardoso is not only the past president of the Brazilian Medical Association, he is also member of the Council of the Conselho Federal. He is a surgeon from Fortaleza, and as I said, most important, the man who brought us there. It's your stage, Florentino.
Thank you, Otmar. It's a great pleasure to stay here. I am amongst friends, Otmar, Professor Rui Nunes, Ramin, and Miguel Jorge, friend and brother. I will speak in Portuguese, so sorry. It's better for me. But Ramin said many times, the most important letter document to WMA is Declaration of Helsinki, many times. But the most pronounced word here is Fortaleza. Fortaleza. The best city in Brazil. The most beautiful too. Friendly people. And beautiful beaches. The water is warm. I'm here to represent CONFEMEL. It's a Latin American, Ibero-American confederation. Now in Portuguese.
Florentino, may I, I'm sorry, but most of us will not understand, or some of us will not understand.
I know.
There is no translation.
Okay.
And Jack.
No problem.
Okay.
Don't worry.
Thank you.
Go ahead. Next one, here. Principle and position of the CONFEMEL. The Declaration of Helsinki is a document of minimal ethical principles for medical research on humans, including research on human material. We must be considered as a whole, and a paragraph must not be applied without considering all other relevant paragraphs. CONFEMEL statement about recommendations or observations to Declaration of Helsinki revision. There is controversy regarding paragraph 33 on the use of placebo. The CONFEMEL changed your mind to better, I think so. But we must protect our patients. If you are testing something about one disease, for example, it's important that you don't must use placebo if you have any other kind of treatment. Never. Or if you are testing, is some risks or more risks than another treatment. These reasons are not specified in the declaration itself, leaving the justification for them before the ethics committees of the countries. The statement itself recognizes risks, but also warning that great care must be taken not but to abuse it. The third one is current redactation on this paragraph 33 does not provide anything new with respect to the old paragraph 29 on the use of placebo in this circumstance. Its language is not clear for us. It raised new doubts and furthermore, it introduced great decision-making openness for local medical ethics committees in clinical research, which do not have the same legal and ethical guarantees in this field in all countries. One parenthesis, when we find to move the last revision of the Declaration of Helsinki 11 years ago to Brazil, is to promote more and more knowledge about Declaration in Helsinki in our country. More than 200 million of people. For in every clinical trial, the same methodological and scientific standard of using and safety, legal and ethical standard must be guaranteed for all countries and all patients. Declaration of Helsinki is to all the countries. Taking special care with especially vulnerable population or communities that need special protection. Some psychiatric patients, for example. The Declaration of Helsinki contemplates the special guarantee and protection required by any clinical trial. However, they are not sufficiently reflected in the word of the last sentence of paragraph 33. We request this review, modifying the current wording, including the reference to special protection that we mentioned in leaving the methodological, scientific, and pressing issues that are alleged in the declaration itself that not sufficiently explained. It should not to be investigated with a placebo in humans, whether there is an alternative pharmacological treatment. I talked about a few minutes before. The last one, the value of the dignity of the human person is a supreme and unavoidable good when it comes to the ethical and legal approach to research and human rights are above all. The dignity of the human is a substantial and inherent value, so personal interest is supreme. Since the human is unique, individual, and unrepeatable, its primacy over any other interest is disruptive. The use of placebo or no treatment is a safe study or treatment where no proven methods effective. We discussed a lot of CONFEMEL about this, especially in March 2023 in Uruguay. The new Declaration of Helsinki review process was initiated by the WMA, considering the process is appropriate and timely. The time is change principles, customs. The working group abroad and diverse integrations, very good. The holding regional meetings an inclusive model to discuss the new revision. The topics identified in the work group for the review's focus coincide with the concern of the medical organization that are members of the CONFEMEL. This General Assembly of CONFEMEL declared it's necessary to address new topics on the Declaration of Helsinki, like artificial intelligence and big data. It's necessary to improve the paragraph related to environment care, inclusion of vulnerable population, informed consent, misuse of unproven therapy. We see a lot of unproven therapy during the last epidemic. Approve include monitoring of side effects. Reaffirm this position concerning the last two reviews and use the placebo and participants' access to post-trial benefits. Some special questions about our country, Brazil. Declaration of Helsinki is June 1964. The last revision, October 2013, Fortaleza. It's necessary to respect the laws of each country. It's about 15 years we are discussing a new law about research in Brazil. It's not easy to change it. It's not so easy to evolution. But last May 28, 24, this law is approved. In Brazil, we have two cameras, Federal Camera and Senate. We approved the new law about research on Federal Camera, but it's necessary to approve too on the Senate. Patients interested after clinical trial conclude. For example, if I have a very successful trial and I use some patients, 100 in each arm, for example, how long I must to take free this medicament, this drug to the patients. In Brazil, there is one discussion about, for all the time, 2 years, 5 years. Guarantee of access to the best treatment. And think about negligence or hair disease, as I say here in Brazil, because the number is so short, hair disease, when you are testing any drug, for example. Then, I hope to learn more about the other speakers and with the audience. Thanks so much.
Thank you very much, Florentina, for your thoughts and bringing in again the Latin American perspective. And during the past revisions, especially the Confirmel group and our colleagues from Latin America have challenged this process quite a bit. And I would like to ask now one of our past presidents, one of the presidents of the 3 presidents of the World Medical Association, which have come from Brazil, Professor Miguel Jorge, to start with his reflections on the presentations which we have heard on the revision process as a start into the discussions, which we would like then also to lead with you together by asking us questions, by giving your comments. But first, Miguel, it's your word.
Thank you, Otmar. Thank you, Professor Rui. Thank you for inviting me to comment on this session. Before I will make my comments, I would just make an addition to what Florentino has said. Actually, the law 14874 was approved and sanctioned by the President of Brazil, and it will come to effect on the 28th of August. And this law changes a lot the CEP-CONEP system in Brazil, which is something that everybody is very much concerned about, because we don't know very well what will happen when the law came to effect. But I will make some comments about the revision, or the current revision of the Declaration of Helsinki. I think, first of all, I want to recognize the improvements that were made since the public comment period 2. I have the opportunity to take a look at the current version that will probably be discussed and approved in the Washington meeting that Jack Resnick has mentioned, and probably his final approval by the General Assembly of the World Medical Association next October in Helsinki. So I think I want to highlight these improvements. I think the inclusion in paragraph 6 of the concepts related to global justice and the engagement of our participants and communities, since when the research is being developed, before being proposed up to the end with the dissemination of results, I think it's a very good thing. Also, I want to highlight that the inclusion in paragraph 7 of the concept of social value and the importance to public health, not just for the individuals who, for instance, has those kind of situations that are being studied by those research. I am glad to see that sustainability of research with human beings is enforced in paragraph 11. And as was mentioned before by Jack and by Barmin, the improvement of the involvement of vulnerable people in paragraphs 19 and 20. I think there are some other things, but at my consideration, those are the ones that I wanted to highlight. I have some questions for the discussion that could be by Jack or either way by Ramin. The Declaration of Helsinki is aiming to medical research involving human subjects, or now participants. I have the opportunity to be in both sides of the balcony. I was a part of the work group who revised the Declaration of Helsinki previously in the previous version, but I was also for 6 years a chair of the Research Ethics Committee of my university, seeing lots of research that are being proposed. In my university, at the beginning, we are just a medical school, Escola Paulista de Medicina, and the Research Ethics Committee was created under that field. So we are just analyzing research that was doing when we're conducting in the medical school. But now we are a university with 6 or 7 campi in different areas of knowledge, and we are seeing many research that involves humanities and social sciences. And there is a tendency in my committee to apply the same considerations that we use for biomedical research when those research are being. And this is a very difficult situation for us. So I would ask to you, what is medical research? Is research where at least one physician is involved, or there is another kind of concept of medical research that is the object of the Declaration of Helsinki? I think this needs to be clarified. I don't know if we have time for this revision, but I would place this situation for you. The principles that would apply to biomedical research are the same that we have to use for those other kinds of research in humanities and social sciences. When I was doing a literature review to prepare my presentation as of yesterday here in this meeting, when I was speaking on new technologies, the innovations, the impact of innovations in research, I take the opportunity to take a look at the new Artificial Intelligence Act from the European Union. And one of the basilar things that is structured that act is the different levels of risks. So it's different when we consider risks in biomedical research from the risks that we see for participants when they are participants in social sciences research, which is also related to health many times. So how this could be, in a way, being touched by the Declaration of Helsinki. Besides of that, is any group of data extracted from public sources like Facebook, Instagram, Twitter, now X, derived from a not personally identifiable group of individuals to be considered as human subjects? So what are the aims of research? Human subjects. We have lots of data now being researched, come from public, from the web. Are these to be considered things that are human subjects and that needs to follow the principles of the Declaration of Helsinki? And I think the last thing that I would like to place to be comment is how we can consider the requirement for informed consent during a public health emergency such as the pandemic, or when we are using a biobank, large data banks, or even, again, doing sociological research. On regards of the informed consent content, when informed consent produced during the, when information is produced during the research are not part of the content of the informed consent. Because sometimes when we use artificial intelligence, generative artificial intelligence, data are being produced during the process. And it's impossible to predict what will come to include in informed consent. How we can deal with this matter. So I think these are the things that I would like to place to be commented by our previous speakers. Thank you.
Thank you very much, Miguel. I think there was already a whole bunch of questions, if not challenges, you have raised, and together with the ones that have been raised by Florentino, especially the question of the use of vulnerable groups, the question of use of placebos, and also the respect or the notion of access to post-trial or post-trial access to care, which is important for that. Maybe I give the word first to Jack to comment on the questions that have been raised by Dr. Cardoso on the question of placebo use. What has the work group so far thought about that?
Thanks, Amar. Yeah, I mean, I think, we had this singular meeting exclusively focused on this issue, and as Ramin predicted, we do hear a whole spectrum of viewpoints as to whether the existing document is too conservative or too liberal on this front. I think the consensus that we heard coming out of this is that the balance that is largely struck in the document is a good balance. We're not proposing to weaken any of the items that are in there right now related to placebo. Confamel has actually been very helpful along the way. We have made some small language changes that have been suggested by Confamel. So I think we're in a good place on placebo, but we're certainly open to additional feedback. I really was struck by Miguel's comments around this notion of what is included in medical research. Miguel, you really struck right immediately to what I think is a fascinating and interesting question. And we've had a lot of discussions over the course of the last 2 years about that term medical research. There have been discussions about whether we should change to health research to broaden to the types of research that are coming to your ethics committee at your university. And it's something we have struggled with, I think, as our commenters have struggled with as well. On the one hand, there clearly are things that might not be included in traditional medical research that we might want the declaration to apply to. So if somebody is doing a study on food insecurity and whether having healthcare professionals and physicians be able to write prescriptions for a food pantry and randomize people to this and see whether it affects their future development of diabetes, that's probably something we'd want to wrap our arms around and think about those participants and their rights and the responsibilities of the researchers. And yet there are other things under the umbrella of health research and that larger umbrella that happen in the social sciences that probably have very little to do with medicine and the origins of this document. So we continue to kind of weigh the risks and benefits of changing that language. We have not put out a proposal to change from medical to health at this point, but we're still gathering input on that.
Thank you very much, Jack. Another question that Florentino raised was the question of the abuse of the term of research and science. What we have seen during the pandemic, when very spooky experiments were done, or when individuals tried to sell their self-invented remedies under the auspices of so-called science. Will there be a response in the Declaration of Helsinki to that in the new version?
that to me, or Ramin, do you want to take
Yes,
that one?
yes, Jack, I think you're on the spot.
Okay, I'm on the spot. So, I mean, I think this falls in a couple of categories under the declaration, and it's interesting. You know, this is not a new problem with this pandemic. I think about my own country, the USA, and our American Medical Association, which is about 176 years old, not as old as some of the medical associations around the world, but it was really founded out of snake oil remedies and trying to put a stop to that. And so this is something we've seen for hundreds of years. So there was this one piece that I mentioned where we actually are adding language to the declaration just about the notion that public health emergencies don't change the Declaration of Helsinki, and that every single protection listed in the declaration still applies during public health emergencies. It may be possible to speed up ethics committee review, to speed up the publication process and still maintain all the same protections. And some of that innovation may be very important during a big public health emergency. But the maintenance of those protections is very important. And then there is this last paragraph really on unproven therapies. And there was a word in the old version of that paragraph which basically said, and I don't have the, actually I do have the old language, in the treatment of an individual patient where proven interventions do not exist or other known interventions have been ineffective, the physician, after seeking expert advice with informed consent from the patient or a legally authorized representative, may use an unproven intervention. And I think the intent behind may use was to say, hey, this happens sometimes. We have compassionate use and other mechanisms. But the word may was called out by some of those folks peddling snake oil and interventions that we knew or had been proven not to work, as to say the DOH actually gives me permission to do that. And that was certainly not the intent. So we have proposed a rather substantial rewrite of paragraph 37 to get rid of that word and to rephrase it to say, yes, there are mechanisms that different countries use to allow unproven therapies to be used by individual physicians and other healthcare providers. When that happens, the following things are very important, and to restrict it to sort of the relationship to the research enterprise, which is, A, we don't want patients experimented on without all the protections of the DOH. And therefore, those consultations are very important. B, we don't want the research enterprise and the benefit to the rest of public health and social benefit and the community to be lost when this happens. So the importance, for example, of actually sharing the data when appropriate from those individual interventions. So those, I think, are the two things probably most closely related to that issue.
Thank you very much, Jack. From Miguel, there were 3 questions which actually related to new technology, or actually the use of big data and AI. And if I may summarize them correctly, you said, first of all, what are the different levels of risks and how can they be taken into consideration in an ethical regulation there, which we have. You also mentioned about the use of public available data for medical research, because it may be flowing into medical research without people knowing that their data is being used, or how have they to be asked. And how should we then consider the requirements for informed consent in these new circumstances which we have? There's another question, and I think you, Florentina, also raised it as a challenge. Have we looked into the question of AI and those technologies when we were discussing the Declaration of Helsinki? And maybe I start with the last point on AI and new technology. After you have met in Confirmel, we had the session in Copenhagen. And in Copenhagen, we discussed the question of new technologies and new research strategies and new data use in classical research. And the question was, does this change, or does this bring up a need to change the principles in the Declaration of Helsinki? Jack, would you like to respond to that? Did you find a need to change the principles?
It's interesting, even at that Copenhagen meeting, we really were all looking at each other and basically agreeing that around new trial designs, while there are specific things like expertise within the ethics committee that are very important, that we couldn't find aspects of the declaration that probably needed to change, and that most things applied to new trial designs. On the other hand, I think the issues around AI and big data and the substantial new world that we're entering around risk of loss of privacy and confidentiality related to those, it was felt that the current language didn't adequately address that, because it really is a substantial new risk, and biobanks just are not adequately, it's not broad enough to sort of deal with all the genetic issues and the big data issues. But I think, we heard from Miguel this issue of data source. And is it, if somebody's using a publicly available thing like Facebook, is that medical research that would be subject to the declaration? And there are certainly gray areas there that I think largely get left to research ethics committees to decide if something is exempt. One of the things that we really are addressing, because of the nature of the Declaration of Helsinki being focused really on participant research and medical research using human beings, we're really focused on secondary use of research data as an important thing, so that when somebody enters a research trial and data are collected from that research trial, there are important things around the consent process for entering that trial related to how those data will be used in the future. Will they be sold to a large data technology company? Will they be utilized in additional research projects? And that to the extent possible, the consent process needs to include those discussions. And that there are times where there's unforeseeable secondary use, and sometimes where you actually need to go back to participants maybe for additional consent where the risk is high, or other times where we put in language essentially saying, if it's not possible or feasible to do that, which you can imagine those times will arise, and we certainly heard from countries about this, that you still need to go to a research ethics committee to get a thoughtful external review about whether unforeseen secondary use of data are important. I guess lastly, as to the Facebook issue, if you're really just gathering something that's publicly available, depending on the risks that you're adding to the participants and the level of identity that you're using, it probably wouldn't fall under the umbrella of medical research, and it's certainly not secondary use because those data were not gathered. The Declaration of Taipei might be more likely to come into play than the Declaration of Helsinki there.
Thank you very much, Jack. And I think that's an important hint. Some of the questions that you have raised, Miguel, are certainly already addressed in the Declaration of Taipei, which then is an extension of the Declaration of Helsinki into the field of data research on biobanks research. At this point, I would like to invite you, if you have questions to the panel, and please come forward to raise those questions. That's now the opportunity to ask or to make comments if you so wish. Yes, please, there is one.
My name is Vinicius Nina. I'm the president of the Brazilian Society of Cardiovascular Surgery and also a member of an American charity, which is CardioStat International, that offers cardiac surgery to underserved population, especially in Africa. So my question to Jack is, in your opinion, there is any important change regarding in this new version regarding the vulnerable population? And the second question is, does this new version brings any observation or consideration regarding humanitarian work in underserved areas of the world?
Thank you for the question, and thank you for your service and your medical work. I'd love to hear more about it sometime. So yeah, the vulnerable populations is one of the more significant changes that are being proposed in this go-round and that have gone out for public comment in phase 2 based on these 3 regional meetings. And as such, paragraphs 19 and 20 have been substantially rewritten. One of the changes that I sort of hinted at in my formal comments earlier was this change in language from talking about vulnerable groups, where really, we as the researchers from on high might paternalistically identify what we see as vulnerable groups, to language that talks more about communities and individuals and groups who are experiencing vulnerability. And that acknowledges their role in identifying themselves at times when we don't see that vulnerability. And B, it really acknowledges that it's not just fixed factors that we think of like gender or LGBTQ status or incarceration, but that there are contextual and dynamic factors that can make people more or less vulnerable at different times for different reasons. And the other change here is really trying to strike this balance between, on the one hand, we know that we need special protections for vulnerable groups. We have looking at the history of where the Declaration came from out of World War II, and then all of the many abuses we have seen over history that have involved vulnerable groups, that this is an imperative that has to stay here. But we have also seen the results of sometimes maybe being too firm and are, again, sometimes from the research perspective, defining those vulnerable groups and what they should or should not experience. And that there are times when those communities actually can have their vulnerability perpetuated or exacerbated by just automatic exclusion from research. And we had many examples about, for example, the lack of data on drugs and their effects on women, their effects on pregnant women, their effects on younger patients, because those groups are so systematically excluded from research. So there's more discussion of kind of responsible inclusion and then sort of separating, and we don't get into the details of defining this because the Declaration is a high-level document and it would be 100 pages long if we decided to try to define what is particularly vulnerable. But the acknowledgement that there are particularly vulnerable groups where the rules around subsidiarity and the requirements to be included in research being very strict, but larger groups experiencing vulnerability for whom we need to really focus on responsible inclusion and what that looks like. So that's really what we've tried to do with paragraphs 19 and 20. Thank you for the question and the comment.
Thank you, Jack. As a longtime companion of the World Medical Association and a critical observer to us, would you also like to comment on the process?
Thank you very much. I would like to make a comment on this last intervention of Jacques Resnick. A recent report of the World Economic Forum stated that if women's health was equally good as men's health, it would immediately inject in the global economy more than $1 trillion. Of course, the problem is not the economy, is ethics, is justice, is global justice. But my comment or question is, why does this happen? Because it is not only a matter of less access to healthcare. It is essentially because data for human research is not from women, and the research and clinical trials, even in the animal, is in the male participant, and in human trials also. So there is not enough research on diseases specific of women, but even in regular diseases that affect both men and women for different reasons, the results are biased for men and not for women. And therefore, the results can be no other than the one that exists right now. And my comment question, although Jack has already mentioned it, is if this issue that affects more than half of the world's population, so it is a special vulnerable group because it's half of the population of the world, it has been addressed by these preparatory meetings of the WMA.
Thank you, Rui. I'm not sure who wants to answer, maybe Jack again, the question of inclusivity.
Well, all I will do is I just want to second the important comments about why we are where we are. And I don't think there's a single explanation, but we know a lot of the driving factors, and how much each of these are at play probably varies geographically, but one only needs to look at who was driving the research enterprise for the last century to explain some of what we're seeing. It has tended to be men. in research positions. And fortunately, we have diversified our research enterprise, but obviously not enough. So that's a piece of it. There are aspects of paternalism and not doing research on women to protect them that have been problematic. In some cases, it's just pure misogyny. In some cases, it's political. There are so many different drivers of this, but I think the comment about women's economic access to economic power and access to healthcare and access to the research enterprise are tremendously important.
Thank you, Jack. If there's no other question, then maybe there's one more, and then I will make a final comment because I have been reminded that we have to close. The lady over there in the fifth row, please.
Thank you to all the panelists for a very timely and insightful presentation. I think 2 congratulations are firstly in order for the success of the revision process so far, as well as for, I didn't know that the Brazilian law has in fact been adopted, so many congratulations to the government. It's a much needed law. I'm Nishtha Arora, I'm a healthcare lawyer, so I think my question would pick on to the legal regulatory aspects of the presentation. And any of the panelists can answer it. It's not addressed to anyone in particular. I noticed one point in the presentation which called for the need to respect for laws of each country, which indeed is important because otherwise the best of ideas can just be aspirational if they can't really be implemented. So I think my question is that what is being done to ensure this respect part of laws in practice, in the implementation, in the revision process rather, or is the onus on the medical practitioners in their respective countries once they are working through the revisions and adopting them in practice? If I'll just sort of summarize it, is something being done in the revision process about it, or does the onus lie on the medical practitioners? Thank you so much.
Good question. Admar, can I take a piece of that and bounce one piece back to you?
Please, please.
And the piece I want to take is just a clarification because this does get misunderstood sometimes when the language in the declaration about how the declaration interacts with national law. And because this is a core ethical document, we see it as setting a floor but not a ceiling. So when we say that it supersedes national law, we mean that a country cannot, through its legal process, or really ethically should not through its legal process, undo any of the protections of the Declaration of Helsinki or weaken any of those protections. But to the extent that a country would like to add protections, that is certainly a worthy and ethically possible approach. Admar, you might have a bit to say about the work over the arc of these years that the WMA has done and continues to do to try to continue to make sure that this document has influence and is picked up by countries and regions.
Thank you, Jack. Yes, the Declaration of Helsinki indeed has made it into many of the laws on, for instance, pharmaceutical testing, on clinical trials in some of the countries. It has been referenced in the European regulation on the clinical trials. So it has become kind of a binding instrument, at least a very important landmark. The World Medical Association itself has no power to enforce anything. We have only the power of the argument which we can give and the hope that it has been heard. But looking back at the time of 1964, at that time in most countries there were no laws on clinical trials. That was the beginning actually. And here I would like to come back on the question of inclusion and inclusivity of the research as a final remark in reflection of the development of the Declaration of Helsinki. 1964, already far away from the Nuremberg trial, the Declaration of Helsinki was adopted under the impression of the thalidomide crisis. You may remember that at that time, thalidomide was a medicine that actually was given very often to pregnant women, and it turned out that it produced very severe mutilations to the embryos and to the fetuses, and children were born without arms and legs at a large number. And I have been told in interviews and talks to people who have been part of the crafting of the first version of the Declaration of Helsinki that this was the most important impression they were under when this was done. And this was also the starting point that then nations started to have laws on clinical trials and to regulate them. I think it's too easy to say, well, this was benevolent paternalism. I think there was a lot of fear that with experimentation there would be repetitions of these events in that. And that has made, of course, big liability charges to industry and to others doing experiments with that. So it would be a little bit too easy just to blame it and saying, well, this was a male paternalism to that. I think there was a real danger that we had seen at that point, or they had seen at that point, and came forward. For my own observation in the past 30 years, I can tell you that when we did the revisions in 2000, when we did the revisions in 2008, there was a lot of pressure on the World Medical Association to exclude verbatim the research, for instance, on children. There was a lot of pressure to exclude the research in poor regions. We did not do that because we thought that, of course, there has to be research for children and for specific diseases occurring in children with that, and you can do them only in children. We, of course, said there has to be a research participation of poorer nations and poorer regions, and we have to include them and not to exclude them from that. And this has completely changed. What we have seen now as a challenge is, why are you not including women, as it has been asked here? Why are you not including pregnant women in research? Why are you not including poor, resource-poor communities in the research? And yes, this is now the challenge to bring this in and to make clear that participation as patients and as researchers for those groups is of crucial importance for the development of research, for the protection of these groups, for the service of these groups, and also for the development of the healthcare systems. And if there is no further questions, then I would like to close and ask Rui to give a final word and then leave us for lunch. Thank you.
Thank you very much, Otmar. It was an excellent panel. Thank you very much to Jack Resnick that is with us by Zoom, all the participants in this panel, and I wish all of you a good lunch. See you at 2 o'clock.
Thank you to our speakers for their insightful presentations. We will now have a lunch break. We will return to our activities at 2 p.m. with the parallel sessions. Please refer to your program for details on the sessions you are interested in attending. For those participating in the working lunch, please proceed to the rooftop. You may also take this opportunity to view the posters and to enjoy the art exhibition by Isabel Saraiva. The exhibition is located in the outdoor area, so feel free to step outside and immerse yourself in the beautiful artwork. Please ensure you return to the auditorium at 4 p.m. for the final sessions and at 6 p.m. for the closing ceremony. Thank you and enjoy your lunch.
you.